We'll get started then. Okay, good morning, everyone. My name is Andrew Chen. I'll just be a bit lazy and recycle the slides from PS Peppa Pig. And if you do have any questions at the end of this, feel free to ask me and find me on Facebook or Messenger. I'm happy to answer any questions that I can. Probably a lot of the stuff you guys will have seen before, so I'll just try to brush over the things that I think are a bit less important, and then just try to let you know what I think is a bit more important and what you should know. All right, so first we'll start off with the hip bones. So you no doubt will know the ilium, the ischium, and the pubis. So there's just some landmarks that you should know. So with the ilium, you should know the iliac crest, as well as ASIS, which is the anterior superior iliac spine, and the anterior inferior iliac spine. And you also have these two at the posterior side. So you have the posterior superior iliac spine and the posterior inferior iliac spine. On the medial side, you have the iliac fossa, and on the lateral side, you'll have your wing of the ilium. The landmarks of the ischium are quite important. So you have your ischial spine, and you also have your ischial tuberosity, which is the bit you sit on, and it's also an attachment for your hamstring muscles. You also have your ischial ramus. Actually, let's just see if I can get my pointer up. Yep, there we go. So this is your ischial ramus. And then I don't think the pubic tubercle is shown on here, but you also have a superior and inferior pubic ramus. And you also have a pubic symphysis, which is just where the two pubis bones will meet. And all of these three bones will meet at the acetabulum, which will help form the knee joint with your femoral head. Oh, not the knee joint, sorry, your hip joint. This is just a photo for your reference. I do believe you get the slides, so if you would like a more detailed view, this is just from Netters. All right, moving on to the femur. Not too important, but there are a few things you should know. So obviously there's a head, shaft, and neck, and the neck just connects the two. You should probably know the trochanters. So there's a greater trochanter, which is lateral, and you can actually feel it on yourself if you palpate the side of your hip, basically. It's also a site of attachment for many gluteal muscles, including the gluteus medius and minimus, as well as the piriformis. And the lesser trochanter is more posterior medial, and it's the attachment site for iliopsoas. So these trochanters also connected. So there's an intertrochanteric line that connects on the anterior side and trochanteric crest that connects on the posterior side. All right. So with the shaft of the femur, there's a ridge of bone that you should know on the posterior surface called the linea aspera, and it has two lips. It has a medial and lateral lip, and these split both proximally and distally. Proximally, the medial lip becomes the pectineal line, which the pectineus attaches to, and the lateral lip becomes the gluteal tuberosity for the gluteus maximus. Distally, the medial supracondylar line will become the adductor tubercle, and you'll also have the lateral supracondylar line. The supracondylar lines aren't too important. All right, distally, you would know that you have your condyles and epicondyles. So the condyles will articulate with the respective menisci. You'll have two menisci, medial and lateral. And the condyles also merge anteriorly, so they will form this small depression for your patella, basically. And posteriorly, you have something called the intercondylar fossa. It's not too important either. Another picture for your reference that you can always look at in your own time. All right, just a little bit on the patella. It's not super important either. So it's located in the patellofemoral groove, which we just mentioned, and it's a sesamoid bone. So that means it's a bone within a tendon. So superiorly, it's connected to the quadriceps tendon, and inferiorly, the patellar tendon inserts onto the tibial tuberosity. So these are two fairly important tendons. So the function is to protect the knee, and it will also act as part of the lever to enhance the action of quadriceps femoris. The hip movements you guys should know already, so I won't talk much about that at all. And a bit about myotomes. So myotomes are always good to remember. I think the lower limb is sort of nice to remember. So if you start at your hips and you start with hip flexion, you can see that it's 2, 3. And then if you move down to the next joint, the knee, you can see that extending the knee is 3, 4. And then if you move down to the ankle, you'll see that the next action of dorsiflexion is 4, 5. So it's quite nice in that it's L2-3, L3-4, L4-5, and then with plantar flexion, you get S1 and S2. Knee flexion is a bit different. It's L5, S1. So you could just that one you kind of just got to remember, doesn't really follow the pattern. But it is quite sequential to knee extension. So it's L3-4, and the flexion is L4, L5, sorry, S1. So it's a bit sequential there too. So that's good to remember. All right. Moving on to the hip joint. So you should know that this is a ball and socket joint, and it's composed of the acetabulum and the femoral head. You have something called the acetabular labrum, which, like in your glenohumeral joint, is a fibrocartilaginous ring, and it just helps make the joint deeper. So that helps the femoral head be more stable. There are some intracapsular ligaments and the extracapsular ligaments, and these just help give stability. They're not too important, but I would mention that in the ligament teres, or the ligament of the head of the femur, it does have a branch of the obturator artery, and this does supply blood to the head of the femur. But the important thing to note that is that this is not a major blood supply. So if you do get your blood supply cut off from the neck of the femur, it's not going to be enough to sustain the head, and there will be osteonecrosis. There's a bunch about extracapsular ligaments that I just put down if you're curious, but it's really not that important. So I think we'll just move on. All right, moving on to the compartments of the thigh and the muscles. You have 3 compartments. You have an anterior compartment, a posterior compartment, as well as a medial compartment. Each of these compartments will sort of have their own innovation and pretty unique overall functions. So let's see. All right, a table, very detailed, good for reference. You don't need to remember the exact proximal and distal attachments, but I have this throughout the slides. So it's always good to look at, and it's just from Moores. But I think you guys will appreciate diagrams a bit more. So firstly, you can see iliopsoas, and this is your major flexor of the hip. So it's composed of your psoas major, your iliacus, and there's actually a small muscle called psoas minor that you can't really see here, but psoas minor doesn't really get mentioned much, so it's not too important. Something to know that is the psoas major here, because it arises from the lumbar vertebrae. It's actually innervated by the lumbar anterior rami. And here we can see pectineus, which is from the superior pubic ramus, and attaches to the pectineal line of the femur. And you can imagine that this would help adduct and flex the thigh. Finally, sartorius. So this is from your aces to the medial tibia. This helps flex, abduct, and laterally rotate the thigh, which kind of makes sense if you think about this muscle shortening. And all of these in the anterior thigh are innervated by your femoral nerve. All right, moving on to the extensors of the knee. Let's see. So you have some vastus muscles, and they all originate from the femur, while your rectus femoris actually is from the anterior inferior iliac spine. And you can see that all of them form this common tendon that inserts onto the patella. And once again, all of them are innervated by your femoral nerve. The vastus muscles are quite easy with their names, because medialis, medial, intermedius would be intermediate or in the middle, and lateralis would obviously be lateral. So that's all good and well. So now we'll move on to the adductors of the thigh. So the major adductor here is adductor magnus, and you should note that adductor magnus has a hamstring and an adductor part. And the important thing about this is that the hamstring part is innervated by the sciatic nerve, whilst the other ones are innervated by your obturator nerve. So the adductor muscles largely originate from the inferior pubis, as you can see, and obturator externus, which it's hard, you can see here, is for external rotation and originates from the obturator membrane, you can see here, and obturator externus for external rotation. That can help you remember its action. Sorry guys, I know there's a lot of muscles, but I'm just trying to go through them as quickly as I can. Just highlight some overall things. I know it's a bit dry, but yeah, we'll get through it eventually. All right, moving on to the gluteal compartment. With the gluteus medius and your minimus, let's see. So you can see them here, minimus and then medius. So these are important for abducting and medially rotating the thigh. Whereas your gluteus maximus, which you can see attaches more posterior, is important for extending your thigh, and it will also assist with lateral rotation. So something always good to remember if trying to figure out the function of the muscle is just vaguely knowing where the muscle is, and then imagining the fibers of the muscle contracting and just seeing what direction that would move the bone. Something to note is that the maximus is innervated by your inferior gluteal nerve, whereas the other gluteal muscles are innervated by your superior gluteal nerve. The tensor fascia lata, the piriformis, and your obturator internus, and the gemella muscles here, as well as the quadratus femoris here. They all help laterally rotate your thigh, and they all attach on or near the greater trochanter. So because the attachments are so similar, you can probably imagine they have the same function and they'll help laterally rotate your thigh. Something else to note that is your tensor fascia lata and your gluteus maximus. They all insert onto this iliotibial tract, which is this fibrous tract that runs down the side of your leg, and it helps your body with stability. Okay, moving on to the knee flexors and the hamstring muscles. So all of your hamstring muscles have an origin with the ischial tuberosity, except for the short head of the biceps femoris. Let's see. Yeah, the short head here, which is kind of hard to see because it's been covered by the long head. So they all insert onto your tibia and fibula, and they're all innervated by your sciatic nerve. Except for the short head of the biceps femoris, which is innervated by your common fibular nerve. So that's the exception. Semitendinosus and membranosus both extend the thigh and flex the leg, and they can help with medial rotation as they are on the medial side. And your biceps femoris flexes the leg as well and can help with lateral rotation as they are on the lateral side. Okay. Something else to note that is there's something called pest and sternus, which you have probably heard of. Which translates to goose foot. So this is the conjoint tendon of sartorius, gracilis, and semitendinosus all together. And apparently this looks like a goose foot. I don't really see it. Maybe you guys do, but yeah, that's where it gets its name. And they insert onto the medial part of the tibia. So this is something they test from time to time, though I don't really particularly see its importance, but it is something they've tested before. And then we'll move on to the sciatic foramen. So with the sciatic foramen, you should know two ligaments, the sacrospinous, which is sort of self-explanatory. So sacrospinous from the sacrum to the ischial spine, so sacrospinous. Sacrotuberous from the sacrum to the ischial tuberosity. And it's these two ligaments that form the greater and the lesser sciatic foramen. So you can see the greater sciatic foramen here and the lesser sciatic foramen here formed by these two ligaments. With the greater sciatic foramen, you can further divide it into a supraperipheral foramen and an infraperiform foramen. This is because the piriformis muscle actually goes through the greater sciatic foramen, and it will leave these two holes here that become your supraperiform and infraperiform foramen. So through the supraperiform foramen, you get your superior gluteal artery, vein, and nerve. And through your infraperiform foramen, you get your inferior gluteal artery, vein, and nerve, as well as some others, including the internal pudendal artery and vein, and the pudendal nerve, and the sciatic nerve, which is quite important, and we'll talk about a bit more later. All right, moving on to the lesser sciatic foramen, not to be confused with the infraperiform foramen. This one has the tendon of obturator internus that you can see here. And it's also got the internal pudendal artery, vein, and the pudendal nerve, which we just talked about and we said came from the infraperiform foramen. So what those nerves and vessels do is that they actually kind of do a turn medially quite quickly just after they exit to go back through the lesser sciatic foramen. And from there, they'll go into your pelvis. All right, just a quick note on the obturator canal. Your obturator foramen is actually mostly covered by a membrane called the obturator membrane, and it leaves a little small hole. This small hole is called the obturator canal. So through this small hole, you'll have your obturator nerve, your artery, and your vessels, and all of these will come out to innervate the medial compartment of your leg. Okay, the inguinal ligament is very important, so it's something you should definitely know. So the inguinal ligament is a ligament coming from the aces to the pubic tubercle. And the structures that pass under this ligament are quite important, including your femoral nerve, your artery and vein, as well as some lymphatics, and they all enter the femoral triangle. There's some landmarks you should know as well. So if you take the midpoint of the inguinal ligament, which is just halfway between your aces and your pubic tubercle, this is where you can find your femoral nerve. And if you use the mid-inguinal point, which is halfway between your aces and your pubic symphysis, you can find the femoral artery here. And if you ever do get confused about whether it's the nerve or the artery, you can use something called navel. So navel is useful for remembering the contents of the femoral triangle from lateral to medial. So firstly, you get femoral nerve, artery, vein, and the empty space, and then lymphatics. So if you forget which one's which, if the mid-inguinal point or the inguinal ligament is the femoral nerve or the femoral artery, you can think about it like this. The mid-inguinal point will go from the aces to the pubic tubercle, whereas the mid-inguinal point is from the aces to the pubic symphysis. And because the pubic tubercle is more lateral than the pubic symphysis, that means the midpoint of the inguinal ligament will also be more lateral. And what's more lateral of the artery or the nerve? The nerve's more lateral. So you know that the midpoint of the inguinal ligament has to be the nerve. And that's just how I remember it. Sometimes I used to get confused between whether it's the femoral nerve or the artery, but this is how I remember it now. All right, moving on to the femoral triangle. So it's this area that you can see outlined by a purple dotted line here. It's an area in your legs, and it's good to know some of the boundaries. So you should definitely know that the superior boundary is your inguinal ligament. It'll be helpful if you can know that your lateral border is the medial border of sartorius, and that your medial border is the medial border of adductor longus, though there is some debate. And that the roof is just some fascia, and your floor is iliopsoas, pectineus, and adductor longus. I personally haven't bothered to remember the floor, but it's there for you if you like to. And so the space is fairly, well, superficial. It's not covered by as many muscles, and it's useful to access for things like surgery. All right, talk a bit about the femoral sheath. So the femoral sheath is this fascial compartment basically that has 3 compartments, and these compartments will contain your femoral artery, your vein, and your medial compartment will contain some fat and sometimes an inguinal load, as well as some lymphatics. So the boundaries here is not too important to know, but something I would note that is the femoral nerve that you can see is not within the sheath. It's actually outside of the sheath, and that the opening at the abdominal end of this femoral sheath is called the femoral ring. All right, we'll move on then to...
a question for you, Andrew.
Yep.
What's the difference between the femoral sheath and adductor canal?
The adductor canal. Okay, I will cover the adductor canal later, so we'll get to it eventually if that's okay.
All right, yeah, thanks for telling me.
Yeah, we'll have a slide coming up in a while, not too quick, but in a while. All right. So the tibia, you guys probably know the tibia fairly well, so I won't spend too long on it. So the condyles here, unlike the femur, is quite flattened because it's so weight-bearing, and instead we call it a plateau because it's been flattened so much. Between your condyles are some tubercles that can are attachment sites for menisci and ligaments. You might have heard that there's 3 sort of surfaces for the tibia. You can actually feel the medial surface on, which is basically a shin, the medial surface of the tibia, if you try it on yourself. The tibial tuberosity is important because that's where the attachment site of the patellar tendon is, and between these 2 bones, the fibula and the tibia, you should know there's an interosseous membrane, which you probably do already know as well. And on the posterior surface, you have a soleal line, which is for the attachment of your soleus muscle. Okay, so you can see that distally, it sort of widens a bit, and there's a bony projection, and that's just your medial malleolus. Your fibula, because it's such a weak bone, it has no function of weight bearing. It's really just for muscle attachment. And distally, you can see that it forms another malleolus, the lateral malleolus, and like some other landmarks, you can feel your malleoli if you just give it a try. All right. Just quickly on the knee joint, it's a hinge joint. There's flexion and extension, and there's articulations between the femur, tibia, and the patella. The tibial femoral part is the weight-bearing part, and the patellar femoral part is where just the patella is. Not too complex here. I would recommend knowing your menisci and ligaments of the knee. They do like to ask about injuries here. So I'll just tell you quickly what menisci are. So they're fibrocartilage. It helps to deepen the articular surface for stability, and also acts as shock absorbers. You can see that they're C-shaped, and they attach to the insular condyle area of the tibia. The medial meniscus is also attached to the medial collateral ligament and the joint capsule as well. So when one is injured or torn, the others can also become injured. And this injury of the three is known as the unhappy triad. You can notice also that the lateral meniscus is a little bit smaller, and it doesn't have these extra attachments like the medial meniscus, so you won't get those injuries. The collateral ligaments are the ones on your side of your knee, and they attach from the epicondyle to the tibia and the fibula head. So these are important for preventing excessive medial and lateral movements of the knee and keeps it in a hinge motion. The medial collateral ligament opposes something called valgus force, which is if you try to bend your tibia and your fibula outwards laterally in this direction. And then your lateral collateral ligament opposes varus force, which is if you move your fibula and your tibia head medially. And it can be confusing to remember. I've been taught sort of a weird way to remember, and it's sort of hard to convey over Zoom. But if you imagine someone riding a horse, that's sort of the position your legs would be in if you applied varus force. So your knees would be outwards and then your feet are coming in. So that's sort of like moving, moving your tibia and fibula inwards, and that would be varus force. So just remember varus is a person who rides a horse or something, and try to think about the position you would be in. And valgus force is where your sort of knees are touching, so knee knocking, and your feet would sort of be outwards laterally, and that's what valgus force would be. All right. The cruciate ligaments are also good to know. I would recommend knowing them. And a fun fact, the cruciate just means cross. So because these ligaments cross each other, that's why they're known as the cruciate ligaments. So the anterior cruciate ligament, it attaches from the anterior intercondylar region. And as we mentioned before, it does blend with the medial meniscus. And this will actually go posteriorly to attach to the femur. And this prevents anterior dislocation of the tibia. The posterior cruciate ligament attaches from the posterior region and ascends anteriorly. And a way to remember the directions of these is an acronym called PALM for the PCL, for the posterior cruciate ligament. So PA refers to posterior to anterior, and LM refers to lateral to medial. So then you can remember that the PCL goes posterior to anterior, lateral to medial. The ACL is a complete opposite. So you know that the ACL then must be anterior to posterior and go from medial to lateral. Some more reference pictures for you here. Okay, we'll now go through the bones of the feet. Not too important, but so we'll go through it quickly. So the talus is your yellow bone here. It's the most superior one. It helps transmit the weight from your legs onto your calcaneus, which is the purple bone. There's three articulations. The one with the calcaneus called the talocrural joint. That's your ankle joint, so you should know that one. That's subtalar joint. And then anteriorly, it also goes with the navicular bone, so that's your talonavicular joint. Your calcaneus is the purple bone. It's the largest bone because it's bearing so much weight. So there's the subtalar joint, which is the one where you can help. There's a subtalar joint. And then anteriorly, there's also the cuboid bone. So that's calcaneal cuboid joint. That's not too important. what is important to know is that the calcaneus protrudes posteriorly, and this is the calcaneal tuberosity, and this is where your Achilles tendon will attach. Some more bones is your navicular and then your cuneiforms. Your cuneiforms is 3 of them, a lateral, intermediate, and medial. And you also have a cuboid form, cuboid bone. And these are all attached to your metatarsals, not too important. And okay, metatarsals and phalanges, not too much here either. So your metatarsals, they can have 3 or 4 articulations with the tarsal bones with each other, so for the intermetatarsal joints as well as the phalangeals. And phalanges, something to note is that from 2 to 5, all of them have 3, a proximal, a middle, and a distal phalanx, whereas the first digit only has a proximal and a distal phalanx, just like your hands. Another reference photo for you here. Something more important, I would say, is the ligaments of the ankle, because they will probably ask you on some sprains. So the medial ligaments are also collectively known as the deltoid ligaments, the 4 of them together. And so they all sort of fan out from the medial malleolus, and they'll attach to your talus, your calcaneus, and your navicular bone. So the main function of these ligaments is to resist over-eversion. The lateral ligaments are formed of 3 separate ligaments, and these all originate from the lateral malleolus. There's an anterior talofibular one, so from your talus to your fibula. There's also posterior talofibular one, as well as a calcaneal fibular one. So you can see where they're going by the basis of their name. So what's important to know is a bit about ankle sprains. So you should know that your lateral strains are much more common. So if you look at your medial strains, that one you would be spraining is your medial ligament. So if you try to, evert your foot, you'll find that you can't really evert it very much. You won't go very far. So that's why it only accounts for a small percentage of your ankle sprains, about 20%. In a lateral sprain, you can see that you can invert your foot much further than you can evert it. So lateral ligaments are much more commonly damaged, and they cause about 80% of strains. You can also have a syndesmosis injury. So that's the bit between your tibia and the fibula. And so this is less common, and one situation that it can occur is you have excessive dorsiflexion. And for example, you didn't see a hole in the ground and it was fairly deep, and you accidentally just walked into it, and there's quite a big impact, and you've like overly dorsiflexed your foot from the impact. That can lead to a rupture. All right. A bit more muscles, and then we'll move into some nerves and arteries, and then a few clinical conditions or clinical things that you should know about. Sorry, the muscles are a bit dry, but I think they're good revisions, so we'll just go over them quickly. Some gifts here. That was made by P.S. Papa. Excellent work by them. But you guys would already know this, so we'll move on. All right. So the anterior and the lateral compartments of your lower leg. The anterior compartment muscles, so the 3 you see, all of these ones. So they all arise from your tibia and fibula, and they have a variety of functions, but the important thing to note is that they are all innervated by a deep fibular nerve. Your tibialis anterior here will insert onto the medial and actually plantar aspect of the foot, so it's actually just wrapping around to the bottom side here. So you can imagine that it helps both with dorsiflexion and also inverting the foot, because it's on the medial side and it's on the plantar side. Your extensor digitorum longus attaches to your lateral 4 digits, whereas your extensor hallucis longus attaches to the great toe, and this will just extend your toes. Your fibularis tertius is quite a small muscle, and it just helps with dorsiflexion and inversion. And then if we have a look at the lateral compartment, which is your fibularis longus and brevis, these are innervated by a superficial fibular nerve. So the tendon of fibularis longus actually travels across the foot, while the fibularis brevis attaches to the lateral side of the 5th metatarsal. So you can imagine that they both help evert the foot. Okay, so fibularis longus tendon, it actually just goes under the foot and it traverses across to the other side, and this helps evert the foot along fibularis brevis. All right, moving on to the superficial posterior compartment. So these three muscles here together, they form your famous Achilles tendon or your calcaneal tendon. So yeah, they all insert onto the calcaneus, and these are all innervated by your tibial nerve, and they all help plantar flex the ankle. So gastrocnemius originate from the femur, while soleus originates from the tibia and the fibula. And something to know with gastrocnemius, because it originates from the femur, if you flex your knee, you can sort of imagine that this muscle gastrocnemius is kind of going to shorten in a sense, and it's not going to be as effective at plantar flexing. However, because it's soleus, on the other hand, it doesn't really cross this joint, and so even if you flex your knee, it's sort of going to be the same length. It will still be effective at plantar flexing your foot, even if you do flex your knee. But that's a minor point, not too important. Okay, moving on to the deep posterior compartment. So the posterior compartment is all innervated by a tibial nerve as well. So tibialis posterior, you can see here, and you can see its tendon here, actually inverts onto the medial plantar aspect of the foot. So it makes sense that it can both plantar flex and it helps invert the foot. Flexor hallucis longus originates from the fibula, and it attaches to the great toe to flex it. Flexor digitorum longus originates from the tibia, and it attaches to the other 4 digits to flex them. The popliteus is quite a weak muscle, and it's going from the lateral condyles of the femur, and it sort of weakly helps flexes the knee, but it's also known for being involved in unlocking the knee for flexion, for knee flexion. So it unlocks the knee by rotating it, and then you can flex your knee. Okay, talking a bit about the popliteal fossa, which is something we should know about. It's this diamond-shaped area on the posterior knee, and it's the main path by which your vessels and nerves pass between the thigh and your lower leg. So it's good to know the borders here. You should know the superior medially, you get your semimembranosus, and superior laterally, you get your biceps femoris. Inferior medial border is a medial head of gastrocnemius, while the inferior lateral border is the lateral head of gastrocnemius. The floor is probably not as important. It's the knee joint capsule, as well as your popliteus and your posterior femur. And your roof is made out of the popliteal fascia, as well as your skin. So you should know the contents here that include your popliteal artery and vein, as well as your tibial nerve and your common fibular nerve. So the nerves here are actually the two most visual contents, and you can see that the common fibular nerve follows the bicep femoris tendon along the lateral margin of your popliteal fossa. The deepest structure is actually a popliteal artery, and there's also something that's not shown here called the small saphenous vein, and the small saphenous vein just comes up your lower leg, and it'll pierce the popliteal fascia and passes between the 2 heads of gastrocnemius here to empty into popliteal vein. So if you Google image, that will come up, but it's not too important. All right, the muscles of the feet, not too important in my opinion, so we'll go through them quite quickly, and there's quite a lot of them, so they're sort of hard to remember, to be honest. So you can see that all of these muscles are innervated by your medial and lateral plantar nerves, and that your first layer of muscles come from your calcaneus, and you can figure out what they do just from their name. So abductor hallucis is going to abduct the big toe, abductor digiti minimi going to abduct your little toe, and your flexor digitorum is going to flex. So quite self-explanatory. The second layer is kind of interesting in that both of the muscles are related to the tendons of flexor digitorum longus. So your quadriceps plantae is going to attach to these tendons that actually help with its function. It's going to help flex the digits, whereas your lumbricals arise from these tendons. And so the lumbricals are a bit more complex. So they flex the proximal phalanges and extend the middle and distal phalanges. So it's helpful to sort of do the movements with your fingers, in my opinion, to sort of see what that looks like. So flex your proximal phalanges, but your middle and distal phalanges are still straight. And maybe that can help you remember. All right, not too many more muscles to go, just the third and fourth layer and then the dorsum of the foot, and then we'll be done with muscles, I swear. Okay, so these are still innervated by your medial and lateral plantar muscles. The third layer muscles, they largely originate from your cuneiform and your metatarsals, as you can see here. The adductor hallucis also has a transverse head, however, and that's from the plantar ligaments. So it's a bit of a weird muscle. The fourth layer is of your interossei. So the plantar interossei that you can see here, it adducts the 3rd to 5 digits and it will help flex the metatarsal phalangeal joints. The dorsal interossei will abduct the 2nd to 4th digits and it will help flex the metatarsal phalangeal joints as well. Okay, all right, final 2 muscles, we're almost done. Luckily, in the dorsum of the foot, you only have 2 muscles, your extensor digitorum brevis and your extensor hallucis brevis. So these are both innervated by your deep fibular nerve. And they actually originate from the same place. So they both originate from the calcaneus and they will insert onto their respective toes. So digitorum will insert onto 2 to 5, whereas hallucis will insert onto the big toe. And all of them will just extend the toes. So not too bad. All right, an important structure you should know is the tarsal tunnel. The tarsal tunnel is the way for things like nerves and vessels and tendons to enter the sole of your foot from your lower leg. So in that sense, it's quite important. So the roof you can see here is your flexor retinaculum, which is just like the retinaculum kind of in your wrist, except it's on your foot. And it's just this fibrous thing running from your medial malleolus to your calcaneus. Anteriorly, you have your medial malleolus. Posteriorly, you have your posterior talus as well as your calcaneus. And the floor is the surface of your tibia, your talus, and your calcaneus. So there's quite a lot of contents here. There's a tibialis posterior, flexor digitorum longus. You also have a neurovascular bundle, so the posterior tibial artery and vein, as well as a tibial nerve. But the tibial nerve will split into your medial and plantar nerves within the tunnel. There's also a flexor hallucis tendon. And something to note that there's also fibrous septae that goes from the flexor retinaculum and separates it into 4 compartments for the tendons and 1 for the vascular bundle. And something you can use to try and remember all of the structures here is something called Tom, Dick, and Very Nervous Harry. I think it used to be a bit less PG, but I'm not sure. I think, yeah, it's more PG now or something. So Tom is for tibialis posterior tendon. Dick is for digitorum longus tendon and is for artery. V is for vein. Nervus is for nerve, tibial nerve, and Harry is for hallucis longus tendon. So repeat that to yourself a few times and you might be able to drill that into yourselves. Okay. Now we'll have a look at the nerves. We'll have a look at the overview of the nerves, which I think is always helpful. So starting with the femoral nerve, an important nerve, it has roots L2 to L4, and it will travel inferiorly from the tendon, from the soleus major, which you can't actually see here, and then it will pass underneath your inguinal ligament and passes into your femoral triangle. So just a bit below your inguinal ligament, it will divide into an interior and posterior division. The anterior division gives some anterior cutaneous branches for sensory innervation, and it also gives a branch to sartorius and pectineus. These 2 divisions aren't too important. I'm just being a bit too detailed here. So if you just remember the general function of the nerve as a whole, that's fine as well. The posterior division, however, becomes a saphenous nerve, and it will also give a branch to the quadriceps femoris. So we did have a question about the adductor canal before, which we will talk about in a bit. So the saphenous nerve is what goes through the adductor canal, and it's accompanied by the femoral artery and vein, and it exits prior to the adductor hiatus, which is the hole in the adductor magnus. Okay, so the motor function primarily of the femoral nerve is for the anterior thigh, innervates the anterior thigh, and there you'll find your hip flexors as well as your knee extensors. So quite straightforward there. Sensory function-wise, we did have the anterior cutaneous branches that we mentioned. This is going to supply your anterior medial thigh, as well as giving a saphenous nerve, and this continues downwards into your lower leg, and this supplies the medial leg and the foot. All right, so we had a question about the adductor canal. We'll talk a bit about it now. So the canal isn't the whole femoral triangle, as you can see here. The canal itself is actually just this conical tunnel that's in the thigh from the apex of the femoral triangle to the adductor magnus. So it's kind of like a passageway within the femoral triangle itself. That's sort of different. So the femoral triangle is a bit more like of a larger structure, and this is just inside the femoral triangle. So the borders here, anterior medially, you have sartorius, laterally you have medialis, and posteriorly you have adductor longus and magnus. So the contents here are your femoral artery and vein. There's a nerve, the vastus medialis, not important, don't bother remembering that. There's also a saphenous vein, as well as that your artery and your femoral artery and vein, they become the popliteal artery and vein after exiting the canal and going through that adductor hiatus to the back of your knee. And that's where it's becoming your popliteal artery and vein. All right, a quick look at the obturator nerve. Same roots, L2 to L4. After its formation, it actually travels with the fibers of solus major, and it'll emerge from its medial border. And it'll just basically course through the lateral wall of the pelvis. You can see the obturator nerve here, where it will go through the obturator canal here, and then it will go into your medial thigh. So not too bad there. The motor function is basically just innervating the medial compartment of your thigh, so a lot of your adductor muscles, and as well as for sensory innervation, it's also just of the medial thigh, so fairly straightforward there. Oops, I think I skipped one. All right, sciatic nerve, it's quite a big nerve, and it's on the posterior part of your leg, so it has roots of L4 to S3, and something important to note that is it first enters your greater, it enters through your greater sciatic foramen through the infrapiriform foramen. So you can see that it's coming beneath the piriformis. And so after emerging from there, it'll cross all of these muscles here, your gemelli muscles, your obturator, internus. And then after that, it'll enter your posterior thigh. And then at the apex, at the apex of the popliteal fossa, it'll split into your tibial and your common fibular nerve. So on its way, it helps innervate all of the posterior compartment. Something to note that is it can sort of be impinged by your piriformis sometimes, which is called Piriformis Syndrome, I believe. So if it's being impinged by piriformis and the other muscles here, it can get some pain and treatment. If it's really bad, you can actually get surgery. And there's some anatomical variations. So we actually saw a case where I think the sciatic nerve actually went through the piriformis muscle itself, didn't go under it, just went through piriformis. So you do get a bit of anatomical variation as well. All right, the tibial nerve. The tibial nerve is from L4 to 3. It's from the apex of your popliteal fossa, and it travels all the way down, and it will go into the tarsal tunnel. And then distal to your tarsal tunnel, it will terminate into the sensory branches for the sole. So tibial nerve is important for innervating the posterior compartment of the lower leg. Sensory-wise, when it's in the popliteal fossa, it will give off something called communicating branch, and it will combine with a branch from the common fibular nerve, and that helps form the strul nerve, which you'll see a bit later. And that gives sensory innervation to the posterior lateral side of the leg and the lateral side of the foot. Other sensory innervation is in the sole, so it will give a medial calcaneal branch to innervate the skin over your heels, There's also a medial plantar nerve and a lateral plantar nerve, and these innervate your sole and the digits. Okay. Common fibular nerve, not too many nerves to go, is from L4 to LS2. So it begins at the apex of the popliteal fossa we've seen, and it follows, sorry, I think that should be lateral border, the medial border of biceps femoris, but on the lateral side. Sorry, yeah, so that's fine. Inferolaterally, and it'll go over the lateral head of gastrocnemius. So as it's going through the head of gastrocnemius, it'll give off two cutaneous branches for sensory innervation. And then the common fibular nerve keeps going. It enters the lateral compartment by wrapping around the fibular neck. And then it will terminate into your superficial and your deep fibular nerves, which you can see here. So motor function wise, it innervates the short head of biceps femoris, which is the posterior thigh. You'll remember that was the exception we mentioned before. And then the superficial fibular nerve will innervate the lateral compartment of your leg, while the deep fibular nerve innervates the anterior compartment of the leg. Sensory function-wise, the two cutaneous branches moves over the lateral, moving over the lateral head of the gastrocnemius will be important. So you have a sural communicating nerve, which is the one that combines with the branch from the tibial nerve, and that will form the sural nerve. This innervates the posterior lateral leg, as we mentioned. And this isn't to be confused with the lateral sural continuous nerve. So there's a sural nerve and a lateral sural cutaneous nerve. And the lateral sural cutaneous nerve innervates the skin over the upper lateral leg. The superficial fibular nerve, this innervates the anterior lateral leg and the dorsum of the foot, except between the first and second toes. This is important. Between the first and the second toe is your deep fibular nerve. This can be tested sometimes. This is a helpful map. So we can see the saphenous nerve here, which is from your femoral nerve, and it just keeps going down. It doesn't go through the adductor magnus, and it just keeps going down. And this will be the medial side of your leg. We mentioned that lateral sural was different to the sural nerve. So you can see that lateral sural is actually more superior in this superior lateral part of your leg. Your sural nerve is more inferior-lateral. And then your superficial fibular nerve will just be more anterior, and it will innervate the dorsum of your foot. But very important to note that is the deep fibular nerve innervates the webbing between your first and second toes. Another one here for your reference, if you'd like to look at your own time. Now we'll talk a bit about the vascular structures. So the femoral artery is a continuation of the external iliac artery, which you guys probably don't need to know much about right now. So it becomes a femoral artery after it crosses inguinal ligament. It gives off a branch called the profunda femoris, or the deep femoral artery, also known as the deep femoral artery. This goes posteriorly, and it gives some perforating branches. These perforating branches that you can see here perforate the adductor magnus and helps supply the medial and the posterior thigh. You also have the circumflex arteries, which you should definitely know. So the lateral femoral circumflex artery wraps around the lateral side, supplies the lateral aspect. The medial femoral circumflex artery wraps around and supplies the head and neck. So these are two important arteries. You should know that they give the retinacular arteries that help supply the neck of the femur. And if those get broken, for example, if you have a fracture at the neck, if those retinacular arteries get broken, you're going to lose vascular supply to the head. And if you don't do something about that quickly enough, you're going to get osteonecrosis, where the head of the femur just dies. I did mention that there was an artery coming from the ligament of the head of the femur, but as we mentioned before, that ligament and the artery within that ligament isn't significant, and it's not going to be enough to maintain blood supply to the head when these retinacular arteries from the circumflex arteries are broken. All right, the femoral artery keeps going, and it continues down the adductor canal, and once it goes through the adductor hiatus, then it will become your popliteal artery behind your knee. Obturator artery, not too much to say here. It just supplies your medial compartment. So you'll have two branches, an anterior branch and a posterior branch, but it's not too important for you guys right now, at least. The gluteal arteries, you have superior gluteal arteries and inferior gluteal arteries, and they both arise from the internal iliac artery, and they come through the greater sciatic foramen. Once again, they just supply sort of the gluteal region, not too important on the details. Okay, popliteal artery. So it moves through your popliteal fossa, and as it reaches the bottom of your popliteus of the border, it divides into an anterior tibial artery, as well as a tibial peroneal trunk. So peroneal was the old name for fibula, so that's why you sort of see that from time to time. And then the tibial peroneal trunk will then split again into a posterior tibial artery and a fibular tibial artery. So the posterior tibial artery will keep going along the deep posterior surface of your leg, and then eventually it'll go through your tarsal tunnel with the tibial nerve, whereas your fibular nerve descends as well within the posterior compartment, and it'll basically go on to supply the lateral compartment of the leg. The anterior tibial artery here becomes your dorsalis pedis once it enters the foot, which is quite an important artery that you've probably heard of. And you can see right here, so dorsalis pedis right here, and it's a continuation of the anterior tibial artery. So it keeps passing over the dorsal aspect of the tarsal bones, and it will help form this arch that you see here, or the arcuate artery actually. And you can see that also there is a deep plantar artery that connects with the deep plantar arches that you can see here. All right. Okay. Something to know for your clinical aspect is pulses. So your femoral pulse can be palpated at, as it enters the femoral triangle at the mid-inguinal point, which we've mentioned already, which is just a midpoint between the acis and your pubic symphysis. Your popliteal artery is quite difficult to feel because there's that popliteal fascia over it, which is quite tough. And it's lying, and also because it's lying quite deep in that fossa. So you really need to palpate it quite deeply to feel it at all. So if you don't feel it at all, that's okay. That's normal. It's quite hard to feel, but it can help if you get your patient to flex their knee, and that will help relax the popliteal fascia, and so you can palpate more deeply. And you can also palpate your dorsalis pedis. This is just lateral to your extensor hallucis longus tendon and just distal to your navicular bone. So if you find an image online or just Google it, you should be able to locate your dorsalis pedis. It's just distal to your navicular bone. The posterior tibial pulse can also be palpated, and that's where sort of near the tarsal tunnel, so just where it's going to enter the foot. So just inferior posterior to your medial malleolus. Okay, Piriformis Syndrome, which is something I did mention briefly already.
Andrew, sorry, I had another question. Sorry to bother you. I've heard of an anterior tibial pulse and a peroneal pulse. Like, are they like any relevance right now?
We didn't really get those mentioned to us, so I wouldn't really say that's important unless your tutors have explicitly gone and taught you it. It's not something I've personally heard of or really been taught at all. So okay. I would venture on the side of no, but take that with a grain of salt. Maybe your year is a bit different.
Thanks.
Yeah, no worries. Okay, so as we've talked about already, Piriformis syndrome. So you're basically just getting like nerve pain as well as numbness, some muscle weakness in your posterior compartment, and butt tenderness as well. So when you try to go for imaging like X-ray, MRI, basically nothing will come up usually, and there's not too much you can do about it. Not operatively, you can just give some painkillers, some physiotherapy. You can also give corticosteroids. Corticosteroids are basically stopping inflammation. And if it gets really bad, you can have something called a piriformis muscle release, where you're basically cutting a bit of the piriformis to make space for the sciatic nerve. Popliteal aneurysm. So an aneurysm is where your artery kind of balloons up. And so this is important because the popliteal fascia is very tough. So it's not going to extend much when you have an aneurysm. So instead of Instead, the aneurysm will sort of compress on the other contents as a result, that it's not being able to expand much because of that popliteal fascia. So if you imagine that you have something compressing your tibial nerve, you're going to have weakened plantar flexion, as well as paresthesia of your foot and the posterior leg because of those branches that we talked about before. And you can see there's quite a bad popliteal aneurysm here. It's quite large. But an aneurysm, you can feel that because there will be an obvious palpating pulsation. And you can also hear a bruit when you try to auscultate. All right. So femoral neck fracture, which we have sort of talked about before, but quite important, so we'll talk about it again. So the fracture of the neck is the most frequent fracture of your femur because it's sort of natural, and it's also at like 90 degrees to gravity. So it's like bearing the full weight of your body, essentially, or quite a large weight. So it's often the result of a high impact trauma, something like a car crash. And the blood supply here is something we call retrograde, because it's sort of coming back, and yeah, it's sort of coming from like down and up. So in that sense, it's like retrograde, if that makes sense. So it's supplied by your circumflex arteries and your retinacular arteries. So following some fractures, you can damage these arteries. And as we mentioned, then the branch of the obturator artery through your ligament of the head of the femur would be your only supply. However, this isn't enough supply. This artery is not very significant. And so you'll get osteonecrosis if you don't do something about it quickly enough. Something you can know that is the affected leg is sort of externally rotated because the psoas muscle kind of pulls the leg up and it'll externally rotated. It's not a very important point. And treatment's not too important because it's mostly surgery stuff, and you guys are only year one, so not expected to be surgeons. Okay, meniscal tear is also quite important. So as we mentioned about the unhappy triad, it's quite commonly injured together, and that's because it joins with the tibial collateral ligament and the anterior cruciate ligament. So because your menisci are weight bearing, they're actually not very well vascularized, because you can imagine you're bearing so much weight on your meniscus. If you do have any vessels here, you're just going to squash them, right? You're just going to like destroy them. So you can't really get any vascular supply, nor do you have much nervous supply here, because otherwise your nerves get squashed as well. So when you do get tears, which is often because you have excessive rotational force, like you're suddenly turning, you're playing sports and you're suddenly turning, then you can tear your meniscus. So you might hear a pop during the tear, but there's really no obvious signs immediately. That's because there's no neurovascular supply. So it's not going to hurt because there's no there's no neurons, and you're not going to get a ton of bleeding and a ton of swelling right away because there's not much vascular supply. So that's why there's no obvious signs. But after a few days, that's when you might find a few symptoms. You might find that finally you get some pain, finally you get some swelling. There might be some knee stiffness because the tear, the meniscus that's been torn off is getting stuck in your knee joint, and it's making your knee stiff because it's physically getting in the way. And because these menisci give you stability, if you do damage them, you might find that your knee joint is less stable, and so the person starts giving way. They'll just be, you know, trying to play sports or going for a run, and then suddenly they'll just like fall over or just feel very unstable. And yeah, as I just mentioned, the piece of meniscus can come loose and it'll get locked. It'll get stuck in a joint, and that's just locking the joint and giving you that stiffness. All right. Other knee ligament injuries include your cruciate ligament injuries. So talking about the ACL, the anterior cruciate ligament, is probably one you've heard of many times in sports. So it's most commonly injured when you're suddenly twisting, much like your menisci. To test for this injury, you do something called a Lachman test. So you have the patient lying on their back supine, and you flex their knee at sort of a 20-30 degree angle. I probably should have put in some images for you guys. Sorry about that. But if you just have a look on Google Image, you can kind of see what it looks like. It's quite similar to the posterior drawer test. And there's also something called the anterior drawer test, which is basically the same thing, just at different angles. But the Lockman test, I believe, has more evidence for it. It's a better test, I think. So basically, you have the knee flex at 20 to 30 degrees, and you apply an anterior force to the proximal tibia. And so you're basically looking for increased anterior translation. Does the leg come more anterior than it should? Because normally your ACL limits that anterior movement. If it's injured and if it's torn, then you're going to be able to move it more anterior than usual. So that's what this test is looking for. The PCL test is basically the same thing, just backwards. You're moving the leg posteriorly and you're assessing for excessive posterior translation instead. So the PCL, on the other hand, is usually injured when you have sudden impacts. And symptoms, so symptom-wise, you might get popping during the injury, just like your menisci. And you also get instability because, once again, these ligaments are important for stability. You might get swelling because there is more vascularization for these ligaments, I believe. But also some of the time, people actually might not feel pain for some reason. I guess there's just not as much neural supply either. So they may or may not get pain. All right, knee ligament injuries, moving on to your collateral ligaments. So these are basically by blows to the sides of the knee, or if you're twisting your leg. So if, for example, someone's playing rugby and then they're getting tackled from the side, or perhaps they're playing soccer and someone goes for a sliding tackle onto the sides of the foot or the lower leg, you can bend your knees too much medially or laterally, and these will injure your collateral ligaments. So your MCL is injured by excessive valgus force. This is where you're moving your tibia and fibula too much laterally. And so you test this injury by doing something called a valgus stress test. Basically, you're applying valgus stress. So you're moving the tibia and your fibula laterally to put strain on your medial collateral ligament when your knee is flexed at 20 or 30 degrees, and you repeat that stress at full extension. And if they get pain or if it feels like there's too much give, then that's a positive sign. Similarly with, it's a similar test with the lateral collateral ligament. So instead, this time you apply varostress. So this is when you're moving the tibia and the fibula inwards medially. So with all of these kind of ligament injuries, the immediate treatment is sort of just protection. So making sure you're not injuring them further, making sure you're resting, and then applying ice. You can give non-steroidal anti-inflammatories after 48 hours, but there's some debate on whether you can give it in the first 48 hours because NSAIDs can sort of, I think, prevent the formation of like prostaglandins or other things that might help with injury and recovery. And the decision of whether you do have surgery is based on a variety of factors, including patient needs, the extent of the injury, and the age, etc. So you can imagine if someone's an athlete and then they're obviously like moving around a lot, they're an athlete, they really rely on these ligaments, then perhaps you would be more inclined to go for surgery. But if it's someone quite old, they're not moving around as much, surgery might not be as attractive. All right. I think we're nearing the end, which is good because I run out of time in a minute. It's something called foot drop. So this is when you sort of injure the common fibular nerve is a common way where you get foot drop. So because the common fibular nerve wraps around the neck of your fibula, fractures of your fibula can damage your common fibular nerve, as well as you have a really tight plaster cast. If you imagine you have a really tight plaster, that's going to be impinging on your nerve against your fibula. So because your common fibular nerve gives your superficial fibular nerve, which innervates the lateral compartment, you're not going to be able to invert your foot. And because it also gives you a deep fibular nerve, which innervates your anterior compartment, you're not going to be able to dorsiflex. So if you're not going to be able to dorsiflex, you're going to get something called foot drop, as you can see here. Of this guy would be trying to dorsiflex both of his foot right now, but this one's not working, as you can see, so you get foot drop. You also get loss of sensation as well to the dorsal foot, as well as the lateral leg. You can see the innervation here. And because you do have foot drop, you can imagine that when you're trying to walk, your foot is basically just limp. So you're going to get a gait. I believe it's called a slapping gait because you can't control your foot. So basically your foot just slaps the floor each time that you're trying to walk. And good timing because I think it's 11:15. So I think that's my hour. Would that be right, Bhuvan, if you're still here?
Yep, that's your hour. Did you have anything else you wanted to go through?
That's it for my presentation. So I think that's about it.
Yeah, perfect. Thanks, Andrew. That was perfectly on time.
Yeah, that was good timing. Yeah, if you do have any questions, feel free to find me on Facebook. All right, thank you guys.
Okay, so our next lecture is clinical skills. I think Yang is here. Yeah.
Yep. Hello. All right, so I'll be doing the clinical skills and examination lecture for this your year one end of year exam. And basically, due to COVID, I'm pretty sure you guys don't have to actually do like clinical skills and like an examination, but a lot of this stuff is still pretty important because it can still come up in terms of like exam questions. They like to ask a lot of these in their MCQs. Yes, this actually, yeah, I'll put the slides up after, sorry. And a lot of this lecture was derived from last year's lecture for Akil in 2020. And yeah, but a lot of this stuff is also good to know when you like eventually go and finally see a patient. It's kind of scary, but yeah, like taking a history, taking an exam, these are pretty much core skills that you'll need as a clinician. So this is a pretty funny video if you want to watch it in your own time. We probably won't have enough time to watch it today. And basically, we're starting off a history, and then you start off with hand hygiene, your introduction, so what your name is, your first year medical student at Monash. Then you tell them about confidentiality, and you obtain consent before you begin everything. It's very important to identify the patient. You want to make sure it's the right patient, because sometimes when you get the wrong patient, you can mess up like patient details. Oh yeah. Someone in the chat gets the video. Yep. Yeah, so basically it's very easy to mess up which patient you're dealing with, and so it's very easy to mess up patient records and files and that. So it's very important that you ask for their name, date of birth and age, and occupation. And then you can ask them, are you of Aboriginal or Torres Strait Islander origin? And it's the most politically correct way of asking. And I don't know why, but apparently ATSI, the shortening, is actually like rude. I'm not too sure why, but I think Nadita told us that last year. And so then you can move on to your history of presenting a complaint. So you start off with something pretty open. You can ask them, so what has brought you in to see the doctor today? And they'll tell you something pretty vague usually, like in an OSCE, they won't give you too much information. And so you have to ask, okay, couldn't you tell me more about that? And then they'll give you a bit more information. And then you can move on to your WWQQAA and then your BICE. Then you can pick whichever system you think is the most relevant and then start asking questions from those systems. And then you can ask your systemic questions like your fever, weight loss, and night sweats, which usually are accompanied with every history, just to make sure you're like ruling out all those red flags like cancer or some of those extremely like problematic conditions. So then you move on to your past medical history. You're asking them, we'll go like in depth for these a bit later, and your medication history, family history, social history, and then you start wrapping up. So when you're wrapping up, you can ask some things like, is there anything else you'd like to add? Any questions you have for me at all? And if you've forgotten to ask anything throughout the history, this is a very good time to ask it. It's always better late than never to ask these questions because you can still get the marks for them in an OSCE and you'll still get the information from the patient in real life. And you're basically a professional history taker. So with your history of presenting complaint, your WWQQAA like covers a lot of this. So when did it start? Was it sudden? Is it gradually getting worse? So you're basically identifying a time frame. And then where is the problem or the pain? Does it radiate anywhere? So you're identifying the location. And then is it spreading around anywhere? And then you can ask the quantity. How bad is it? And you can put it on a scale of 1 to 10. And it's very important that not everything can be put on a scale of 1 to 10. So like if it's something like a cough, you don't really want to ask like, how bad is it on a scale of 1 to 10? You can ask it in a different way. You can ask how often they're coughing or how bad it is. And then you can ask about the quality. So if it's pain, like you can ask what type of pain it is. So your usual dull ache or sharp pain, like someone stabbing you. And that's also going to differ for the symptom. And then you can ask for the associated symptoms. So is there anything else that's happening at the same time? Like, is there a headache? Is there a nausea or like vomiting or something like that? And did it start around at the same time? So that way, you know, is there anything else going on that we should be worried about? Then you have your aggravating and alleviating factors. You usually want to ask these one by one. So with every question in the history, you want to ask them one by one so the patient doesn't get overloaded. So is there anything that makes it better? Is there anything that makes it worse? And then you go on to your bias, so beliefs. So you ask the patient what they think it might be and how's that impacted their day-to-day life. So concerns, what are they potentially worried about? So hopefully you're addressing your patient's concerns. Like if they're worried about this might be cancer, then you want to make sure that this concern is addressed by the end of like your examination and everything. So expectations, so what would you like us to do for you today? And so what do you hope will come out of the consult? And so going to the MSK systems review, the mnemonic they kind of use is pills with DJC. And so that just stands for pain, instability, loss of motion, loss of function, swelling, weakness, deformity, joint stiffness, and changes in sensation. I think most of these are pretty straightforward, but we'll go over something like instability. So instability just means like, does it ever feel like the joint will just pop out of place? So like when they're moving their arm, does it just feel like their arm's just going to dislocate itself just randomly? And joint stiffness is one that's pretty important because if there's like morning stiffness, it usually means arthritis. And then you can ask them for the duration to find out if it's osteoarthritis or rheumatoid arthritis. Now to the neurosystems review. The mnemonic for this is head swing. And basically you have headache, your like eyes, ears, and nose. Is there anything like visually hearing, like your hearing or your smell? Is there anything wrong with those? Your anesthesia and paresthesia. So anesthesia means you can't feel anything at all. Whereas paresthesia means what you're feeling something, but it's changed. So it might be like numb sensation. It might be like less sensation, like less temperature or touch sensation. And then you have something like dizziness, syncope, and vertigo. So like, is your head... So vertigo is basically when your head's like spinning, you feel like the entire room is like spinning around you. So it's like dizziness, but it's a lot more severe. And it's usually a medical emergency. Are they having any seizures at all? How often are these? Are they really bad? Is there anyone there to witness these happening? They can tell you more about them. Then you have your head injuries with loss of consciousness and weakness, incontinence. So like bowel habits, are they losing the ability to control when they go to the toilet? Any neck stiffness at all? Or any gait or movement problems? So like when they're walking, are they like shuffling? Are they leaning to one side? All of these things might be relevant in a neurological systems review. And another way you can do this is...
Yeah.
Oops, sorry. Did you have a question?
No.
All good.
No, I didn't have a question.
All good. So Yeah, so you can also group these in terms of like which part of the body it is. So like your head stuff, you can have headache, neck stiffness, your head injury, and that kind of stuff. And then your weakness and paresthesia in your limbs, the sphincter control in your abdomen and bowel, and your gait control and involuntary movements kind of in your legs. And then you have your cardiovascular. The mnemonic for this is paid cops are fatigued. Starting off with palpitations, ankle edema, your intermittent claudication, dyspnea, chest pain, orthopnea, paroxysmal nocturnal dyspnea, syncope, and fatigue. So basically, chest pain. So is it crushing? That's usually an emergency. Is it burning? That's usually like reflux. And has it been brought on by exercise? That's probably angina. Palpitations is like when the patient can feel their heart like physically beating. So it can either be benign or it can be like something caused by an arrhythmia. Dyspnea, like it can tell you something like heart failure or AMI. It can cause like fluid buildup in your lungs or something like that. It can cause failure of circulation of the blood. Orthopnea basically means, are you short of breath when you're lying down? And so it usually happens because there's a left heart failure. And so the fluid backs up into your lungs. And the way you can ask a patient about orthopnea is ask them how many pillows do they sleep on. If they sleep on multiple pillows, then that might indicate that they're sleeping at a larger angle, which means they might be finding it difficult to sleep when they're lying flat. Paroxysmal nocturnal dyspnea is, are they waking up at short periods at night short of breath? Your intermittent claudication is, you can ask them like when they walk maybe like 400 meters to a kilometer, are they feeling any pain in their leg? And if they are, then this might be a sign of something like peripheral vascular disease or peripheral artery disease. Ankle edema usually signifies right heart failure because its right heart failure is backing up into systemic venous circulation. And so usually your ankles would be drained by the right heart. But since you have right heart failure, that's where you get swelling in that area. Syncope just means fainting, and fatigue usually indicates heart failure or just overwork. It's a bit of an ambiguous symptom, but it's one to definitely watch out for. And then you go on to your systemic questions, which you can ask with honestly every patient. Are they feeling malaise? So are they just generally feeling unwell? Are they feeling tired at all? Are they having a fever? So fever will tell you a lot of the time if it's an infectious cause or not. Night sweats, and then weight loss. So something like cancer, this is very important, something we definitely don't want to miss. Something like your night sweats, your weight loss, and you're just generally feeling unwell. This might be pointing you towards cancer. Infection, yeah, your fever and weight loss will definitely be like present in something like this. Your thyroid problems might be fatigue and weight loss, and then your anemia might just be fatigue. So onto past medical history. So you kind of can ask about the medical conditions that they have currently. Some of the ones that you should look out for are asthma, hypertension, cancer, and diabetes, because these might exacerbate a lot of the symptoms that a patient might have. So, for example, hypertension, they tell you that they have hypertension. So then you can be on the lookout for more cardiovascular problems, because hypertension will very easily cause other things, like other issues with the cardiovascular system, and it could be caused by something else that's inherently wrong with the cardiovascular system. So it's definitely something to look out for. You can ask for their immunizations. Are they up to date? Any past surgeries, and were there any problems of recovery at all? You can ask for their hospitalizations. So what were they in hospital for? How long was it for? And did they have any issues recovering at all? And you can ask for childhood illnesses, because especially because of chickenpox, it can reactivate to form shingles, which is a very painful rash. So it's definitely something that is relevant in terms of medical history. Medications, you have the drugs mnemonic. So doctor prescribed. So what is it for? Do they have like another condition that they're using these drugs for? The dosage and the time method. So how often do they take it? How much are they actually taking? Any reactions or adverse effects? So are they actually experiencing anything else from the drug? And are they compliant? So are they actually bothering to take the drug at all? So recreational, this is a bit of a sensitive question. So you can reassure the patient that everything you say is kept confidential. And you can ask them what type. So if they like, I don't know, do weed or something, like how do they do weed? Do they smoke it? Do they do it in a bong or something like that? So use the prescribed. So this is just over the counter stuff. So you can just ask them, do you get anything at the pharmacy? So, and then you can ask them if there's any alternative or complementary medicines they take, because if you've learnt in HEP, every single patient is literally dying for you to ask them about their complementary and alternative medicines. So it's just a good one to add in. Then you have your gynecological. Yeah, don't ask this to guys. It happens way too often, especially when you're tired. But you're just basically asking for like your contraceptive methods, like are they on the pill or something like that. Sensitivities, so are they allergic to anything? Most of the time, they'll just put some like random allergy, like they're allergic to prawns or something, like blueberries or something. It's usually not that relevant to the like the case itself, but it's just good to like note down when you're doing the history. So smoking, have you ever smoked or are you smoking right now? You should ask both, because the examiners will be really cheeky. And if you ask them, are they smoking right now? They'll say no. And then it turns out the patient was smoking 10 years ago and they smoked like 30 packs a day or something. And then you just missed some major thing in the history. And then you can ask them how much they're smoking, how long they're smoking for. And so you can calculate the pack years. So what that is basically if they smoke one single pack every day for a whole year, that's one pack year. And then you can ask them about if they've ever thought about quitting. If they do smoke, they usually don't go much further than that. And then you can ask about alcohol. So do they drink? How often do they drink? How much do they drink? And you want to try and put it in terms of standard drinks. So if they just say like, I don't know, like a big glass of wine, you don't know if that's like 5 standards in a glass of wine, or if it's just their concept of big is completely different to yours. So you want to at least try and quantify it in a number that's like standardized between you and them. And so if you suspect excessive drinking, like if they're saying they drink like 5 glasses of wine every day for every week, and then you can start asking the cage questions. So cutting down, like are they feeling guilty? And that, so you can ask them if you suspect excessive drinking. So social history, this is probably the least important part. Like if you're running out of time on an OSCE, you can kind of just skip this, except for maybe diet and exercise. You might want to ask those two, but yeah, we'll just go through it. So like stress, like what is causing it? Like it's pretty straightforward. Exercise, how often are they doing it? How intense is it? So usually like 30 minutes, 3 times a week or something, pretty intense. That's pretty good. It's something like that. Diet, and you want to actually ask them what they eat in a day or a week, because they'll just say, okay, my diet's pretty good. And what does that actually mean? Well, you don't really know. So you can ask them, like, what did you eat yesterday or something? What would you normally eat in a week? Living situation, who, with, and where. This is more important if the patient has like a condition that might stop them from functioning normally. So that might need someone to take care of them. And then the social network and connectedness, are they getting any support from others? So the patient is suffering like significant depression or something, it's obviously important that they have support from other people. You can ask for their hobbies. I don't actually know why, but it just might be just to build rapport with the patients, I guess. One of the mnemonics you can use for this is essence. So education, you're not asking which school they went to, you're more asking how much they know about the topic. So if the patient comes in with like heart issues, so they're having palpitations, The education in this sense is like how much they know about palpitations and what potentially might cause palpitations. And stress management, spirituality, exercise, nutrition, connectedness, environment. Yeah. So when you actually finally get to practice your examinations, it's always good to practice on someone. And so parents and siblings, if you're still at home, is their ideal victims. But if you can't find anyone, you can try and organize a day with your friends to try and practice this. Or I don't know, if you're still lonely, you could just do it on your body pillow or something. But basically, you start off with general appearance in every single examination. No matter what system you're doing, you always start off with the general appearance. And you just kind of want to look, do they look well? The gait, so how they're walking, are they like limping? Is it asymmetrical in any way? Do they have any aids with them at all? Are they on oxygen? Do they have any crutches in with them? Are they in pain? So if they're in pain, you should obviously note this. And if they're in very severe pain, you can get them some pain relief. Body habitus, which is basically like the weight of the patient. You want to try and be nice about this, like when you're actually doing an OSCE, because no one really wants to be told by 50 medical students that they're fat. So you can just say something like, okay, the BMI is noted, or I've made a record of the patient's body habitus. And is there anything else that you notice? So you can just add anything that you can just see from it. Maybe like the patient's skin is yellow, so that might be jaundice or something like that. So vital signs, you have your heart rate, respiratory rate, blood pressure, temperature, and O2. These will give you a lot of information about like the well-being of the patient. If they're in a very serious condition, your vitals will be like, they might be too high or too low, depending on which one you're looking at. So we're more looking at signs of the disease. So signs are objective, that we can see, feel, or like examine, whereas symptoms are subjective, which means they're reported by the patient. The patient is feeling these things. Yeah, and you always examine from the right side of the patient. Yeah, and so you usually go, so we're starting off with the cardio exam and usually go distal to proximal. So a few things that you might want to watch out for in general appearance for cardio is your like whole body inspections for Down syndrome, fans and Turners, and body habitus, because weight can influence a lot of different things and put you at risk for a lot of conditions for cardiovascular diseases. And so you want to start off with your hands. So peripheral cyanosis just basically means at the side, like peripherally in the body, it just looks blue or cyan. And that's usually because the blood perfusion to the area has been impaired. And other ways you can test this is capillary refill. So you press down on like the nail bed. So you can press down on like your nail and see how quickly it returns to being like pink. And if it's too slow, then that might be a problem with the blood flow to the area. And clubbing will usually show you that there's not enough, like there's too much carbon dioxide, there's some metabolic activity or syndrome going on. That's the issue. Then you have tendon xanthomata and tar staining. So tendon xanthomata basically just means like around the tendons of your fingers, there's just deposits of like fat or cholesterol. So they're going to look something like this image here. Like this is more for the eyes. You can kind of see those yellowy patches, and that just might signify high cholesterol or like some congenital factors like hyperlipidemia or something like that. Tar staining is something to do with smokers. So if they smoke a lot, then you might see tar staining in the nails. They're just like black spots on the nails. Splinter hemorrhages, Osler nodes, and Janeway lesions. These are buzzwords for infective endocarditis. So this is something that very easily could come up in an exam. They say the patient has Osler nodes, which you can see they're like on the fingers, Janeway lesions, which are on like the palm or the hand, and splinter hemorrhages, which are on the nails. And then moving on to the wrists, you have your pulses, your radial pulse. You want to note the rate and the rhythm. So how fast is it? And the regularity or the irregularity of it. And so you'll get a couple different types of rhythm. You'll get regular rhythm, which is perfectly normal. It's like at a constant pace, and it's at a, like, there's no, the gaps in between aren't different. And then you get like irregularly irregular, which means that it's irregular, but there's a pattern to the irregularity. So like, for example, like a number sequence 1 1 2 4 1 1 2 4, like it's irregular, but there's a pattern within it. And then you can just get completely irregularly irregular, which is there's just no pattern to the beating of the pulse, and that's pretty severe, and it's probably a medical emergency. Radial delay. So looking at both the radial pulses, is there a delay in the radial pulses or at the same time? And if there is a delay, this is usually indicative of coarctation of the aorta. So that's one that's good to know. Brachial pulse, this is really hard to feel for most of the time. But yeah, it's just like around where your elbow is, like your inside of the elbow. And your radiofemoral delay, basically, it's quite sensitive. So you usually don't test for this. You can just mention the radiofemoral delay in the OSCE and you'll be fine because it's quite sensitive to the patient. Then you can move on to your eyes. So your face now. You can see if there's any jaundice in the sclera, any pallor of the conjunctiva. This usually signifies anemia. So if like you're looking under the eyelid, if it looks very pale, then there might not be enough red blood cells in the patient or enough hemoglobin. So then you have arcus senilis, so a blue ring in the iris. So this image over here. And that basically just means you have a high cholesterol. And xanthelasma, which is basically, you can see those yellow things, those lipid deposits around the eye, is also an indicator of cholesterol as well. Sorry. So yeah, moving on to the face, you have your mitral facies, which is like this red flush that you can see. That's usually due to mitral stenosis, so a problem with the blood flow in one of the valves. Then moving on to mouth, you have central cyanosis. If you ever see the lips or the tongue blue, then this is definitely a medical emergency. It means that they're not getting enough oxygen at all. And if you see like paleness, this might indicate anemia. So high arch palate is one that's a buzzword for Marfan's, and you can kind of see it here. Like you can see how it's like very, I don't know how to say it, but it's like very deep in the mouth. And yeah, that's just a key word for Marfan's, something to watch out for. Dentition can definitely cause heart issues because of infective endocarditis. So like in a question stem, they'll often use that for, like, that's usually a buzzword for infective endocarditis if the patient has very poor dentition. So petechiae is basically just spots on the lips, and that's also indicative of endocarditis. So now you want to make sure that the patient is sitting 45 degrees with their shirt off from their neck and downwards, and you will ask for consent when doing this, obviously. And you want to make sure that this is done as quickly as possible, and then the patient gets to put their shirt on as quickly as possible. So you start off at the neck, you look at the carotids one at a time because of the carotid reflex. You don't want to do both at the time or else the patient might faint. And so you're feeling for the character and the volume. So are you actually feeling the blood flow? Is it like feeling full, like the blood flow going through? And yeah, so are there any like whooshes or anything like that? You can listen with the bell for bruits, so holding their breath. You can listen if there's any like abnormal flow within those vessels. Then you can look for like those carotid aortic valve problems disrupting flow. Then you look for the JVP, and basically you're looking for the double pulse in the neck, because for the carotids you only feel a single pulse, but for the jugular vein you'll feel a double pulse. So you'll measure the height above the sternal angle, and basically you can kind of see, this image is a bit small, but kind of see like the clavicle and sternal angles here, and then they're measuring the height above it. Less than 3 centimeters is fine. If it's any bit higher, then there might be an issue with the heart valves causing a higher pressure over here. So like the blood might be finding it pretty difficult to get into the right side of the heart. So it's like overflowing in the JVP. The abdominal jugular reflex is one that also comes up in the exam quite a bit. That's when you push down on the abdomen for around 10 seconds, and the JVP should rise for a bit, and it should then return to normal after a while. And if it stays risen, then that's abnormal. So now you're onto your chest, and you're kind of doing your inspection, palpation, and then auscultation. So starting off your inspection, just looking for anything like asymmetry, so left and right side, if there's anything different for either the sides, any deformities, any scars, any swellings. And scars can be linked to pacemakers. So when pacemakers are installed, there might be like scar left on the skin. Any redness at all, breathing rate, you can just ask the patient to do something else and then just look how many times their chest like heaves during that period. And you don't want the patient to be aware that you're measuring their breathing rate while you're doing it, because they might change their breathing rate as a result. So you want them to be kind of like distracted. So you can measure their pulse and then do this at the same time. Then you can move on to if you see a visible apex beat or not. So when you're doing the palpation, you can start off with the apex beat. And these locations are very important to remember because they do test them in like the theory component of the exam. So apex beat will be at the 5th ICS mid-clavicular line. And heaves, basically you're using the heel of your hand, so like where your wrist is, the bottom of your hand, and you're doing it at the left of the sternum. And if you can feel the chest basically pushing against your hand, then that's ventricular hypertrophy. Thrills, you're using the base of your fingers, so like your 3 fingers, and then you can basically press on where the valves are. And if there's turbulent flow, then you might be able to feel that. But more likely you'll listen for it in the auscultation. And so these 4 valve locations are extremely important. They'll come up again and again in your exam. So your aortic valve is your second intercostal space on the right sternal border. So this is the only one on the right side. So the pulmonary one is the second intercostal space on the left sternal border. So aortic and pulmonary, they're on the same level. They're just on the different side of the sternal border. Then you have your tricuspid, which is the 4th intercostal space on the left sternal border. You have your mitral, which is the 5th intercostal space on the mid-clavicular line. And that's basically also where your apex beat is. So mitral and apex beat will correspond. Chest auscultation, you want to listen to all 4 of the valves with the bell and the mitral first, then using the diaphragm on all of them. These special maneuvers, you can look at them yourself. I won't go through them that much, but basically, like you can see how these 2 line up vertically, and that's I for inspire. And so these 2 valves here, you listen when they're inspiring. You listen for a lub and a dub, and there should be no other sounds other than these 2. And if there's more sounds, then that's probably pathological, something wrong. And then you can just report S1, S2 sounds are normal. There's a couple of extra things you can look out for, like sacral edema. So when the patient is leaning forwards, like down at their lower back, is there any swelling? Or you can just look for like their pulses, any cyanosis. So is it blue in color? Any pitting edema, which means when you press down on it, it just stays there, forms like a pit, and then any toe clubbing at all. Yeah, so just a couple of quick fire multiple choice. Which of the following would be most commonly found on a patient with infective endocarditis? A couple of answers in the chat. Yeah, A. It's fine. Yep, you'll find oslonodes, January lesions, splinter hemorrhages. Those are the 3 that come together. So which of the following may be seen in right ventricular hypertrophy? Yep, so let's watch some heaps. That's good. So what is the difference between right and left heart failure? Oh. Yep, someone said right is edema in the periphery, so it's backing up. So just imagine when you're looking at the heart, like if there's a problem with the area of the heart, it's the area behind that area or the area that flows into that area of the heart that has an issue. So for the right side of the heart, it's going to be the periphery, so your legs that will have the ankle edema. If it's the left side of the heart, it will be the lungs that have the issue.
Ladies and gentlemen, I think my brain just committed suicide.
Yeah, so you kind of get that when you're studying musculoskeletal exam, which is what we'll be doing next. So basically, before we begin that, were there any questions for the cardio part? You can just send them in, I'll try and answer them after the thing. So with your MSK exam, you start off with the usual. Your general expression is pretty straightforward. There's not that much else you need to look out for. You go for the look, feel, and then you do your movements. So look, the way to remember it is mass deformity. So muscle wasting are there any areas where like there's less muscle mass than usual? Any asymmetry, any scars, swelling or deformities at all? Temperature best is what you're feeling for. So the bony landmarks, unfortunately, is one that you have to know. Swelling and effusions at all. Any tenderness. So tenderness basically just means when you're pressing on the area, the patient feels pain. So it's slightly different from pain because it's only elicited when you're pressing on the area. And then you use the back of your hand. Basically, you can put it over specific areas to test if there's any increased temperature. Might be helpful finding if there's like an aneurysm or something, then there's a lot of blood flow to that area, inflammation, then it might be warmer than usual. Moving on to the move and measure, like you want to do the active movements where the patient does it. You want to do your passive movements where you do it and feel for any crepitus. So that basically means the arm or any of the joints, are they creaking at all? And it's obviously not good when they are creaking. And an important thing to remember is like if a patient just comes to you out of a car accident, you do not passively move any of their joints because you might cause a great deal of pain and suffering to the patient. You want them to do any movement, and if they can't do the movement, they're able to stop whenever they can't do the movement. But if you're doing the movement, you might very easily damage something you don't want to damage, and you might get sued for it. So if they're out of a traumatic accident, don't passively move any of their joints. So special tests, there's obviously joint-specific ones, which we'll go through a bit later. And then you ask about the pain and start on the pain-free side to see what it's like normally. And then you compare with the other side. And you can kind of look at the patient's face to judge if they're feeling like any tenderness or any pain from this. The bony landmarks, like it is what it is. You kind of just have to know these. It's very important to just know like where it kind of is. Like you don't need to get like exactly on the point of where it is when you're palpating it on a patient. So especially for something like acromion coracoid, like all of these are pretty close by. And basically the reason why you need to know this is for when you're like doing your palpation. If you're palpating and you feel any tenderness in these areas, so you feel tenderness in the coracoids, then you can potentially like localize what the problem is. So the coracoid, it might be like a fracture in the coracoid, or it might be muscle attached to the coracoid. That's the issue. So it's good to know like generally where these are, but you don't have to be too specific. Like as long as you don't like when you're palpating for the acromion, you're not palpating the patient's leg, like you'll be fine. Like you just need to be in the general area. And if you feel tenderness, then you can follow up on that with some special tests, but it's not that important. Ranges of motion. This has actually come up in exams a couple of times. I don't think it came up last year, but if you do any of the practice papers, like they will just randomly ask you like what the adduction shoulder range of movement is. So I would probably recommend knowing these. It's not that high yield, but it can come up. Yep, so abduction. So the only one I'll touch on is abduction. When it's passive, when you're holding the patient's shoulder in place, it can only abduct to 90 degrees because the deltoid will take over when you're abducting from even further above. And if you're holding the scapula in place, it can't like go over that 90 degrees. But everything else, active and passive, would be the exact same. Yeah, this one's definitely one to look out for. I don't remember getting range of motion questions last year, but I honestly don't remember anything from exams last year. So take that with a grain of salt, but it's definitely come up in previous years. Like I definitely remember doing past exam questions and it was just like randomly, it was just random like shoulder abduction or shoulder external rotation. What was the angle for it? Yeah, so these are also the exact same for active and passive. Yeah, it's probably not that important, but if you want to learn them, like they could come up in an exam theoretically. Yeah. So now moving on to the shoulder special tests, you have your Hawkins test. So basically when you hold your arm out like this, and then you try and push your elbow down while you support like the patient's upper arm. And so you're trying to internally rotate the arm. And if there's pain, then that's a rotator cuff impingement. So if all of these tests, if you don't like the paint.exe images that I drew for you, there's always images, there's always videos down in the speaker notes that you can go have a look at. But I think most of these are fairly straightforward. So near sign is basically when you internally rotate the arm. So this means that your thumb is facing downwards and your forefingers are facing outwards, and you try and lift the arm up. Pain is a positive sign, and that just shows you rotator cuff impingement. So painful arc, you have your active abduction. So the patient is doing the abduction themselves. Pain between 60 and 120 degrees is positive, and it's usually supraspinatus. That's the issue. Empty can test is basically two internally rotated arms, so thumbs are pointing down again, and then you're trying to press down on those arms. The patient's trying to keep them up, and if there's any pain at all, then the patient probably has some issue with their supraspinatus. Resisted abduction. So basically the patient will have their arms against their sides. They will try to abduct the arms before 15 degrees. So after 15 degrees, the deltoids take over. So right here, we're trying to test the supraspinatus again. So basically, you're trying to push the arms back towards the patient while the patient is trying to lift them off within that 15-degree angle. Resisted internal rotation, or also known as the lift-off test, is basically where the patient has their their palm facing outwards at their back. They're trying to lift it off their back while you're trying to push it into their back. And this one is testing for subscapularis. Resisted external rotation, basically you're doing the robot and they're trying to like externally rotate, so they're trying to move their arms outwards. Meanwhile, you're trying to push their arms inwards. And this is testing for infraspinatus and teres minor. So with all of these tests, you're able to test for basically every single rotator cuff muscle. Elbow tests. So you have medial epicondylitis and lateral epicondylitis. This is something that can definitely come up in an exam. And this is your golfer's elbow and your tennis elbow. So golfer's elbow is medial, so GM, and lateral epicondylitis is tennis elbow, so TL. So medial epicondylitis is testing for flexors. So basically, you can make a fist with your thumb at the top, and then so your arm is supinated, and you ask the patient to move their fist towards their wrist, so towards themselves, while you're pushing the wrist away from them. So you're pushing the wrist away from them, pushing the wrist downwards. Lateral epicondylitis, you're testing for the wrist extensors. So you're making a fist, but this time the arm's pronated. So the person still wants to move the fist towards themselves, so towards their wrist, but now you're pushing it away from them again. But this time the arm's pronated. Does that kind of make sense? You can kind of see like these two. Like this is, it's usually better to make a fist so that it's like easier to push on it and it doesn't test any other muscles. These two definitely can come up in an exam, your Phalen's and Tinel sign. These are both for carpal tunnel syndrome. And Phalen's is your reverse praying. You want to do it for 30 seconds. If there's any numbness or tingling, then that's a positive sign. Tinel's is for tapping over the wrists for a couple of times. And if they feel like numbness or any tingling sensation, that's probably carpal tunnel syndrome as well. Your hip special tests, your leg length, there's two types of leg length. I think this has also come up in the exam before. So your apparent leg length is from your medial malleolus to the umbilicus. So this will test for if there's any like pelvic tilt. So if your pelvis is slanted one way, whereas true leg length is actually the bone length. So from your medial malleolus to the aces. So this will actually test if one leg is shorter than the other. Trendelenburg's, this is definitely very high yield. Basically, you're asking for a patient to stand on one leg, and if it sags to the non-weight bearing side, to the other side, then your abductors, so gluteus medius, and all your other gluteus muscles that abduct are weak. So your Thomas test, which is your fixed flexion deformity, you're lying down, you're putting one hand under their back, and you're asking them to flex their hip. So it's normal if their hip remains on the bed, and abnormal if their hip rises a lot and cannot be straightened fully down. Knee special tests, we'll go through these pretty quickly. If your patella tap, basically you're tapping the patella and then it's positive if you feel fluid. Kind of pathology. I'll try and get to the questions at the end because I think I need to be conscious of time. But yeah, so the bulge sign is basically you're squeezing, you're trying to like juice the knee joint, like, and you're basically trying to like squeeze all the fluid into one area. And if you see like small effusions or any fluid waves, then that's a positive sign. Your collateral ligament tests, I think Andrew went over these pretty well. So basically varus is to test MCL and then valgus is to test LCL. And a way to remember that is varus needs to pee. And so when you're pushing the knees inwards, that's testing your MCL because it's the medial collateral ligaments that are extending. Cruciate ligament tests, anterior posterior drawer tests, I think Andrew's gone over those as well, so I won't dwell too much, but they're there if you need. Ankle special tests, your Achilles tendon integrity test. This has also come up before. So basically, like their leg is this way, and you're basically squeezing their calf, and the ankle will plant effects. So unless the Achilles angle has completely ruptured, you will always get a reflex. So even if it's like partially ruptured, you'll still get a reflex. So this is only testing for complete Achilles tendon rupture. Yep, so you have your peripheral nervous system exam, we're nearly there. This is the last system that you need to do. Basically, you start off with general inspection. So do they look well? Are they in pain? Involuntary movements, posture and habitus. So any deformities, you're looking for deformities, muscle wasting and scars, any swelling, redness, involuntary movements and symmetry. Feeling for muscle bulk and fasciculations. Fasciculations basically just means like flickering of the muscles. So any like involuntary muscle movements. You get that to a normal degree in a healthy patient, but if it's very severe, then you know something is wrong. So movement, there's 4 things you need to do. So tone, is it very rigid? Are the movements very stiff? Is there any spasticity? Power, so on a scale of 1 to 5, are they able to do the action? Are they able to do it against gravity and against resistance? Reflexes, your nerve roots, is it more or less? And your coordination, so like your finger to nose test and dystioid dysdiodocokinesia. So like you're flipping your palm up and down and seeing that they can do that action properly. Going with your sensory tests, you have your pain temperature, which is your spinothalamic, vibration, proprioception, light touch, your DCLM, two-point discrimination, and stereognosis, which basically just means if I put an object in your hand with your eyes closed, can you tell me what that object is? That's for the sensory cortex. Yep. I won't go into too much depth. You just kind of have to know these, like they will come up in an exam. There's not much way around them. It's best to try and look for patterns and trying to group these. So abduction and external rotation of both C5, C6, flexion C5, C6, extension for wrist and elbow of both C6, C7, C8, and then you kind of just work around that. The lower limbs are even more cursed. They're just like completely just whack. So basically, you want to look for a couple of mnemonics, try and be able to learn these. So L2, L3, I need to pee. So hip flexion for L2, L3. L5, S1, S2, I just finished my poo. Hip extension to stand back up, something like that. And you can, there's like multiple that PSPs have probably done, but you can have a look at these yourself as well. The dermatome maps, so basically what each nerve root kind of innervates, you need to know the arm ones, not like the torso ones. But yeah, there's plenty of images on Google, and these does come up sometimes, I guess. So yeah, it's definitely good to know. And the test can give you a rough idea of which spinal nerve might be the issue, but they do also have overlap. So you want the patient to close their eyes, and then you do these 4 sensory tests. So pain, use the neurotip, and you ask if they can feel the pain. Light touch with cotton wool. Vibration with 128 hertz tuning fork. So this is important. This can come up in an exam. They can ask you what hertz it is. Proprioception is basically you're grabbing both sides of their fingers, moving it up or down, and then they have to tell you which way they move. And always make sure to give them a reference first, so you can like show them the neurotip on their chin or the cotton wool on their chin, show them what it feels like, and then you ask them to close their eyes and ask them to do the test. So reflex changes, you have hyporeflexia, so you no reflex or lower reflexes if it's a lower motor neuron lesion, or hyperreflexia, which is a lot of reflex, like higher reflexes if it's an upper motor neuron lesion. So what lower motor neuron lesions and upper motor neurons and lower motor neurons actually are the lower motor neurons, they come off the spinal cord to actually go to the muscle, whereas the upper motor neuron kind of is the one that travels in the spinal cord all the way up to the brain. So you'll learn a bit more about this next year. But since upper motor neuron inhibit reflexes, if you damage them, then there's less inhibition, so that's why they're exaggerated. So for tone changes, you have hypotonia, which is less tone, lower motor neuron, hypertonia for upper motor neuron. Parkinson's, these 3 symptoms are basically like buzzwords for Parkinson's. If you have a resting tremor, slow movements, or cogwheel rigidity, these 3 basically just say the patient has Parkinson's. So in your important peripheral nerves, your radial nerve, median nerve, and ulnar nerve, you need to know the dermatomes for these testing, and you also need to, which these nerves are testing, and then you also need to know kind of what muscles each of them do. So the radial nerve are the extensors of the arm, and so if you have any pathologies, you can get wrist drop, or you can get loss of sensation over that anatomical snuff box up over here. You can test your finger and wrist extension to test for the radial nerve. So for the median nerve, so one of the pathologies we talked about before was carpal tunnel. And so an issue might be you can't abduct the thumb, you can't flex the index finger. So you might get something called the hand of benediction. And then you get the wasting of the thenar eminence, so TM. So thenar is medial. And the thenar eminence basically just means the muscles closer to the thumb. Sensory loss of the lateral 3.5 digits. You can also see kind of from this dermatome image here. And for the ulnar nerve, you'll get C8 to T1 issues. So in your Guyon's Canal, if you have any issues there, you get wasting of the hypothenar eminence, so the opposite side now. you have clawing of the 4th, 5th digits, and you have the weak key grip. So a key grip is basically, imagine you're turning a key in a lock, you're using like your thumb and your index finger, and then you kind of grab the key that way. And if you have a weak key grip, it might be an issue with the ulnar nerve. Then you have a loss of sensation of the medial 1.5 digits. So these digits over here. So one distinction that is pretty important to make is what's the difference between the hand of benediction and the ulnar claw. So they might both look very similar, like you're making a handgun, but they're actually caused by different things. So ulnar claw, as the name suggests, is an ulnar nerve issue. So you're asking the patient to make a fist and then try to straighten the fingers. So the 4th and the 5th fingers can't extend, so that's an ulnar nerve issue. Whereas the hand of benediction is when the hand is extended and you ask them to try and make a fist. The lateral 2 fingers, the index and the middle finger, they can't bend. So that's when you get the hand of benediction, and that's the median nerve. And that's it. I'll have a look at the chat. You swapped around varus and valgus. Actually, I'll have a look. Sorry. So did you say? Varus supply. So what did you mean by that? Sorry. Valgus should be the knocked knee one. Okay, can I have a look for you? Virus stress test. Okay, yeah, I might have swapped that around. I'll change that on the slides. This image might be wrong as well. And someone wanted to explain the test. So that's testing for the meniscus. And basically you're trying to like rotate the leg internally when the knee is extended. So the patient's lying down, you like flex their hip and extend their knee. And then you can kind of like rotate their leg. And basically, if there's like pain at all when you're internally rotating the leg, so you're rotating the leg towards the body, then that might be an issue with the lateral meniscus, so a tear of the meniscus. I'll put in an extra slide for that after. But were there any other questions? All right. Good luck for your exams. And if you have any questions, you can email me or something. I don't know. Thanks for listening.
Okay, thanks, Yang. Can you guys hear me? Sorry, I think something's going wrong with my Zoom. I have like a couple of accounts for some reason logged on. Give me 5 minutes to figure out what's happening. Okay, is that better? I think so. Sorry about that. All right. So the next lecture is HLSD, which I will be taking us for. So let me just open up the HLSD stuff and we can get started. Okay. So yeah, if you guys have any questions or anything, chuck them in the chat or just ask me. I'll monitor the chat while this is going on. And if you guys want me to like go slow or fast, just let me know with like thumbs up if possible. Yeah. All right. So thumbs up for faster, thumbs down for like slower on the content. All right. Where is the present? Okay. So, HLSD, can you guys, is it coming up properly or is it, yeah. Speak of you, lol. All right. Is it better now? Okay. My, my PowerPoint just crashed, so I'm guessing not. Fix this. Sorry, guys. Okay. So, should we go now? HLSD. Just before we start, quick thanks to the previous revision lecturers for HLSD 2020-2019. These slides are like very much just like progress, very much based on their slides. And I also remember using their slides a lot for HLSD revision back in year 1 for my exam. Before we start as well, just a quick content warning. Some of the content HLSD, can be, the topics that we will talk about include gender identity, suicide, psychopathologies like depression, anxiety, and also violence in relationships. So if there is some of this content coming up, I'll include this little content warning just in the top left of the slides, just in case. All right, let's have a look. So what are we going to go through? We're going to go through these 4 broad ideas: HLSD theories, lifespan development, psychopathologies, and then aging and dying. So let's jump into it. So HLSD theories, those are our theories about development. But before we look at those, I guess it's important to clarify some broad frameworks like the biopsychosocial framework. Essentially, we have life being broken down into 4 basic forces: biological, psychological, sociocultural, and life cycle forces. Now with these forces, they're pretty much in their names. Biologicals are genetics, health-related forces. Psychological is our personality, perception. Sociocultural is our interpersonal relationships, the relationship with our society and culture, and then our life cycle forces. So this one's probably the most ambiguous out of them, but basically it's saying that the same event can impact people differently. And that can happen among people, as in between 2 different people, as well as at different stages of lifespan development, such as the loss of a parent to a child has a different impact to the loss of a parent to an adult. So that's what we're talking about, those life cycle forces. So what are some basic concepts? Again, these are pretty much in the name: nature versus nurture. That's our genetics versus our environment and our experiences. Continuity versus discontinuity. Is development continuous, as in it's smooth, gradual, or discontinuous? There's like abrupt steps or shifts in our development. And then universal, context specific. Do we all go through the same development, or is our development different based on experiences? So even though it's like nature versus nurture, it's not necessarily binary. And there will be times where, there will be parts of development which we can see are based more on nature versus based more on nurture. Similarly with continuous versus discontinuous and universal and context specific. All right. So let's look at some of the development theories. The first one is Piaget. Basically, this one is when children are organized into themes or schemes, and the development occurs when you're trying to assimilate into those themes or accommodate those themes, so modify them to fit your development. So this is a discontinuous theory. What are some of the flaws? It doesn't make any considerations for the environment or the culture. It doesn't recognize that mistakes that children make when they're pre-operational might be due to language instead of cognitive development. And also it doesn't recognize sort of the unique differences in children. So children might perform inconsistently in tasks, and children might develop different stages at different times compared to other children. So what are these stages and what are these themes? It's the sensory motor, which is around birth to 2 years old, pre-operational, about 2 to 6, concrete operational, 7 to 11, and 12 through to adulthood. So these 4 stages are really important. And I think that knowing the age, as well as a description of the stage, can give you a really good grasp. So if we look at the description of the stages, sensory motor is pretty much experiencing the world through our senses and our actions. Pre-operational is being able to represent things with words and images, but we can't think logically. We can't think intuitively. Concrete operational is then gaining that logical thinking, and the formal operational is thinking abstract. Yeah, these are pretty important to know, and you'll see in some questions how they're applied as well. All right. The next theory we're going to look at is Freud's psychodynamic development theory. Again, this is discontinuous, but basically divides our development into these 5 stages: oral, anal, phallic, latency period, and genital. Now, the idea here is that we have to negotiate each period before we progress onto the next one. And so we might get stuck in a specific period. For example, if a parent is too critical with a child during the anal stage, then they might remain obsessive throughout life as a result of sort of remaining in that stage. And these stages are also very absolute in the sense that the dilemmas or the development focus in each stage is very specific, right? So in the genital stage, apparently we're ready for adult relationships, even though that starts around 11. So this image that we see on the right here, it does describe the stages. It's good to sort of understand them, but it's not the best. I think having a look at this diagram helps to understand what's involved in the stages a bit more. So in the oral stage, it's more about the weaning in the mouth. So that's stuff like sucking your thumb, satisfying those sort of sensory motor actions, essentially. The anal stage, all about toilet training. The phallic stage, this is where I think the naming sort of goes out of whack. It doesn't really match with the development. So the phallic stage is about realizing genitalia as well as sexuality. But the key here is identifying with your adult role models. So the image, you can see a kid shaving with their parent. And so in that situation, they're identifying with the adult. The latency stage, expanding our social contacts. And it's theorized that it includes repressing our sexual urges to prioritize social development. So that might include social development among people of the same gender instead of the other gender. And then genital stage, this is when your sexual interests mature and you're able to establish family next generation. So again, although this starts at age 11, according to Freud, it's something that continues on for adulthood. All right, finally, Erickson, psychosocial development. Again, this one we should be a bit familiar with, considering the HLSD environment. It is slightly discontinuous, but it is more continuous. And that's because we can see this progression between, we can see that each stage is sort of progressing. It's not a definitive step in each stage. And it sort of comes up with this basis that when we know ourselves, that's what enables us to connect us with others. What should we know about Erickson's psychosocial development theory? I would have a very good understanding of this basic conflict of each stage and knowing what age these stages are. It's pretty important to be able to apply these in the sense of what stage might an individual be in or what stage these basic conflicts are a part of. And we'll look at this a little bit more in depth a little later on in the presentation. But this is a pretty good summary of Erickson's psychosocial development. Just make sure to remember these basic conflicts and then matching up to the stages of development as well. Okay, so then we have Bolt's, Bronfenbrenner, and Banduro's theories. Bandura is the easiest theory here. It's just social learning. We learn by watching others. That's essentially the proposition there. Bronfenbrenner is the theory that the child is surrounded by layers and the development is linked to those environmental contexts. And then Bout's theory is about essentially plasticity. It's about gaining skill and losing skills. So at some points in our life, we will gain skills. At some points in our life, we will lose skills. For example, I'm sure we've all heard that old dogs can't learn new tricks. That's a pretty good way of thinking about Bout's. So on the left, we have Bronfenbrenner's theory. We have the macrosystem, exosystem, mesosystem, and microsystem. I think it's really important to know what each of these systems are. So if we look at the microsystem, that's basically the immediate surroundings of the child: home, school, neighborhood, the immediate family. The mesosystem is the relationship between the microsystems, essentially, or the microsystem, the relationship between home, school, neighborhood, work. The exosystem is more about the community, right? It's the broader social aspect. So that's news media, community services, the child's school, as well as the parents, right, and their workplace. The macrosystem is then the most broadest form of this. It's the cultural and the values and the beliefs of the community as a whole. So I have an understanding of how to work with you, sort of understanding of what each of these systems are and applying them when you get to questions, essentially. So they might ask you what the home fits into or what a specific event fits into in terms of the system. And then Bolt's lifespan development theory is based on these 6 principles. It's a continuous theory. It's lifelong. Gains and losses, essentially both skills, experiences. And yeah, that's pretty much it for these ones. They're not as important. I guess the biggest takeaway is just learning the systems. All right. Finally, information processing. This is not too important. It's essentially just saying that the way that we process information can sort of be likened to a computer. We have our hardware, that's our brain, the actual neural structure, the anatomy of our brain. And then the software is the processes that we undergo to take tasks. So as we age, we can upgrade our software, but our hardware doesn't change, right? It just declines as we become older. And then finally, Watsky's social scaffolding theory and Skinner's conditioning. Watsky's social scaffolding, this is not, in my experience, not too important. Essentially, it's talking about how we learn. So if we look at this diagram, the blue circle represents what we can learn on our own, and then the next circle represents what we can learn with the help of others. And so the theory is that we'll perform better when we have the support from knowledgeable others like our parents, and technology and tools that lets us learn beyond what we are capable of on our own. And then there is a last circle, which is what we can learn or what we can't learn, what is beyond our reach. A good way of thinking about this might be with anatomy. You know, anatomy thinks that we can learn everything on our own, but in reality, we need to learn it with more of their help, essentially. And then finally, Skinner's operant conditioning. So as you guys might remember, there's 2 forms of conditioning in HLSD, operant conditioning and classical conditioning. Classical conditioning is the one about introducing stimuluses or stimuli and reinforcing those stimuli over time. And then Skinner's conditioning is about this positive, negative reinforcement and punishment. So what's the best way of thinking about this? The way that I found really helped is thinking about positive as adding or giving something, negative as subtracting or taking something, and then reinforcement is promoting an action, while punishment is discouraging an action. So if you think about chores, your parents might provide positive reinforcement by giving you pocket money for doing your chores, or they might provide you negative reinforcement, which is taking away your iPad or like taking away your technology for not doing chores. On the other hand, we have punishment then, positive and negative. So let's say you don't do your chores. How are your parents going to discourage that? Well, positive, well, they might give you like a, well, let's say if they're old back in the day, they might slap you or something. And the negative punishment, they might take away again. Negative punishment, they might take away your rights. Like they might take away your ability to go out. They might ground you, for example. So that's operant conditioning. Okay, so let's go through some questions. According to Freud's psychodynamic theory, the key task in the latency phase is what? Oops. Okay. Yep. So A, expanding social contacts. Everyone's correct. Pretty simple. This is still a question that you can get. So know what the phases correspond to. So expanding social contacts, that's the latency phase. Toilet training, anal. Weaning is oral. And then again, identifying with your adult role models is a phallic stage. All right. Next question. The development of a lasting integrated sense of self is a key challenge of which stage in Erikson's psychological theory? Oops. Okay. So I've got a couple of responses. C, exactly right. Identity versus role confusion. So independence and decisions, that's 1 to 3 years old. Trying new things and handling failure, that's an adolescence stage. That's 6 years to adolescence. Identity versus role confusion. That's where we find our integrated sense of self. And then contributing to younger people, that's our middle adult stage. That's like the generativity idea. Okay, so I did get a question just to go back over the differences between negative punishment and negative reinforcement. Okay, let me backtrack. All right. So negative punishment is we're going to take something away to discourage an action. And negative reinforcement is we're going to take something away to promote an action. So yeah, the fine line, it's a bit blurry, right? What the exact difference is between these two. So if we want to promote an action, that will be, we're going to essentially take something away to promote it. So I think the best example would be if we have our chores, they might take away like your iPad, your technology, they might take away, I don't know, something you really enjoy, your favorite toy. Negative punishment, let's think about an action that we want to discourage. So say for example, at school, or let me think of a better example. Yeah, let's think if they want to discourage, if your parents want to discourage like drinking, if you end up drinking, then they might take something away from you that right is. So I think someone came up with a good example. If you play too many games, they'll take away your games. And so what they're doing is they're taking away something as a response to you doing something they don't want you to do. In negative reinforcement, they're taking something away in order to make you do an action. So it's about the reinforcement versus punishment part. Punishment is discouraging and promoting is doing something. Yeah, so yeah, that's also a good point about negative reinforcement, about taking something unpleasant away. So yeah, if we think about what is something unpleasant, they might also, so say for example, you do your chores, they might reduce your chores for the next time. And that's taking away that unpleasant activity of doing your chores as well. Yeah, that's a good point. That is probably a better description of negative reinforcement. Okay. So let's go on to this next question. It might be a bit confusing. So let me know if you guys don't really understand what's going on here. So essentially, let's consider that we're the child and we're looking at this sort of mountain diagram or diorama. We're taking this mountain diorama. And we can see these 3 mountains, right? Mountain X with a cross, Mountain Y, the tallest one, and Mountain Z with a house. And then there's a teddy bear sitting on the other side of that. So the question is, according to Piaget's theories, how would a child in the pre-operational stage describe the teddy bear's point of view? So I'll wait for a couple of responses. A, okay, great. So so why is it A, right? This is sort of what we need to understand. So there's this sort of general, I guess, rule that we can use. In the pre-operational stage, a child is more likely to suggest their own view as they view the teddy bear. And that's because they haven't reached that logical thinking, right? They're just using their intuition. And so based on their intuition, they're going to think that their view is the same as the teddy bear's view. When they get to the concrete operational stage, their logical thinking will realize that their view is different, but they're not able to determine what that view is. And so in that sense, they're going to more likely provide a random view. So if we think about this, Mountain Y, so that's more likely to be option C if they're in the operational stage, concrete operational stage. Mountain Z is going to be the closest, Mountain Y in the middle, and Mountain X is the furthest. And that's them giving a random view, not the correct one. And then finally, formal operational, that's the child giving the correct view. So that would be option B, Mountain Y and Mountain Z and X behind it. Does that make sense? Yeah, you're right. Mountain X would be, Mountain Z would be on the right. Mountain X, yeah. So, yeah, you're right. Mountain X is on the left. Yeah, I can explain that again. Give me a second. I'll just answer this. On the right. So for the teddy bear, mountain X would be on the right and mountain Z would be on the left. But the reason why A is correct is because that's essentially giving them the wrong answer. That's them giving their own view as the teddy bear's view. Does that make sense there? Okay, so if I run through the explanations again, if we think about the preoperational stage, that is about intuitive thinking. And so based on intuitive thinking, they're unlikely to provide the correct view. They're more likely to provide their own view as that of the teddy bear. Concrete operational, they're going to be thinking about, they're more likely to give an answer based on a random view because they'll recognize that the view is different to theirs, but they won't have the correct answer to the view. And then formal operational is, again, they understand that the view is different and they're able to figure out what the view would be. So there's a question about egocentrism being corrected in formal. So if we think about the concrete operational stage, let's revert back to the theory. Okay. So egocentrism is like beginning to be unraveled in the concrete operational stage. So that's why they're able to recognize that the view is different, but because they don't have the abstract thinking, they might not be able to give the correct view, essentially. So concrete operational is more likely to give the random view than the than formal operational. So at the end of the day, if we do remember that children can develop differently, and so at 11 years old, 9 years old, 10 years old, many children can give the correct view still, but that is more likely to represent formal operational thinking than concrete operational. Does that help? Okay, let's move on now. Let's move on to some more lifespan development. So yeah, we'll be going through basically newborn to adult development. Okay, what's important to know for newborn and infant development? Essentially, we have these three factors, and these can impact the development of a child. So nutrition, if there's inadequate maternal nutrition, notably that can lead to premature birth and low birth weight, as well as spina bifida, can be a result of a lack of folic acid. How important are statistics for these topics? That is a good question. Statistics are the most important thing for HLST. What is more important is sort of knowing what can result due to this issues in development, essentially. So nutrition, right? Important to know that premature birth and low birth weight can happen from inadequate maternal nutrition, as well as spina bifida and folic acid, the relationship there. Maybe an important statistic for age would be that I think 50% of pregnancies that happen above the age of 40 result in miscarriage. But it's not essential. It's unlikely that they're going to ask you specifically about statistics in HLST. So I think I mentioned this at the start, but there's 15 questions for HLST. And so if we think about it logically, we're going to get questions on our theories of development. We're going to get questions on infant development, but I don't think statistics will be that high yield for this subject. Okay, so stress, maternal stress is also associated with low birth weight and premature birth, and that's due to two reasons, both bad coping mechanisms like alcohol and smoking, and also the release of stress hormones. And then age, again, as I mentioned before, the older you are, the likelier you are to have a miscarriage, stillbirth, or difficulty in getting pregnant. What are teratogons? I hope I said that right. Essentially, they're agents that will cause abnormal development or abnormal prenatal development. What are the important ones to know here? I think thalidomide and alcohol. Know that these two drugs are known teratogons, and what they do. So thalidomide will cause deformed limbs and digits, and that happened in the 50s. The images are really horrible, but that sort of shows you the impact of the drug. And the alcohol as well can lead to fetal alcohol syndrome. And what will that mean for a child? That will mean some form of intellectual disability or some heart problems. Diseases can also be teratogons. Again, don't really memorize which diseases these are, but know that they can lead to these impacts like neurological disorders, deafness, blindness, such and such. And then environmental hazards also, like lead poisoning, mercury poisoning, PCBs, and as well as X-rays. So we have, again, what they can lead to: intellectual disabilities, slow growth, cerebral palsy, impaired memory, and verbal skills. This, I think, is the more important part for teratogens, teratogens, I guess, probably a better way of saying it. What's the key with this little diagram on the left? Essentially, this is showing us at what time of development, what parts of our body are susceptible to these agents. The key one here is the brain and spinal cord, which is susceptible for most of the developmental period. If we compare it to the other parts of our development, they're less susceptible at times. And so the CNS, brain, your spinal cord, at specific risk. And then this table here, I think, would be a good table to memorize for the drugs, knowing which one of these drugs have what impacts. So alcohol, aspirin, caffeine, cocaine, heroin, marijuana, and nicotine. Those are the important drugs, as well as thalidomines. Okay. AGPA scores. What is an AGPA score? Essentially, an AGPA is conducted 1 minute after birth and 5 minutes after birth, and it assesses the condition of a newborn. So each of the letters represents something else. A for appearance, that's the skin tone. That basically represents, as we can see, blue, pink, extremities are blue, or pale or blue. That represents sort of the circulation of our blood, right? If we're pink, got good blood circulation. Extremities are blue, we've got bad circulation to our extremities. And then pale or blue in general, we have bad circulation in general. We might not be circulating blood at all. Pulse, again, similar. We want to assess the pulse of the child. That represents how well their heart is going. Grimace stands for reflexes. Are they reflexing? Are they grimacing? Again, the score is here to know if they have if they're crying and they're pulling away, then they have the adequate reflexes. But if they're weak, if it's a weak cry or a weak grimace, then it's not as strong. And then no cry, no grimace, that's a very bad sign. Activity, muscle tone, essentially assessing the movement of the child, and respiration, which is the breathing effort, right? If we look at the scores of 0, we can see that all of these together sort of imply that the child is in a very, very bad state, if not alive at all. Whereas pink is, complete perfect conditioning. Complete perfect condition. So anything above 7 is good. Anything from 4 to 6 is needing special attention, and anything 3 or less is life-threatening. Which makes sense, because to get a score of 3 or less, you really have to get a score of 0 a couple of times, which will indicate a very serious condition. What are the reflexes to know in newborn development? This is a pretty good summary of them. Most of them are pretty obvious in terms of the name, like blink. Eyes are going to blink when we're responding to bright light or loud noise. The palmar reflex, grabbing something when it's placed in the palm of our hand. Stepping, suckling, and withdrawal. But the ones that are a bit hard to memorize are Babinski, Moro, and rooting. Babinski is our toe fanning out. Our toe fanning out when we just stroke our foot from heel to toe. Moro is throwing our arms out and inwards. That's basically to catch on to the mother when we would fall. That's the origin of that. And then rooting, that's described here. It's basically to help the baby find the nipple. So what's important to know? Definitely the response. And I have seen questions before about significance of these reflexes. So I would be pretty comfortable with this table. Newborn states, we have 4 states: alert and activity, waking activity, crying, and sleeping. Crying is sort of underrated. It does come up. I have seen a question about what crying indicates, what sort of state. So have a general idea of this. Basic crying, we're just crying because we're babies. When we're mad, the crying is going to be intense and loud, and then pain is going to be loud wailing, pausing, and then gasping. So they might describe what type of crying a child is going through, and they might ask you what that represents. Whoops. But the other states are pretty self-explanatory. What's important to know as well is the sleep cycles and how they change. So our newborn sleep cycle is 4 hours, 3 asleep, 1 awake. When we're 3 to 4 months, changes to 5 to 6 hours. And then 6 months, it's a 10 to 12 hour cycle. All right. And then temperament, it's not too important. Essentially, we're just saying here that temperament is stable, but our genes can influence our temperament, more so in the negative way than the other dimension. So for example, like anger, frustration, that part of our temperament is more affected by our genes. This is something to definitely be comfortable with. We want to know what types of locomotion senses children gain at what age. So it's a bit hard to memorize because it's just like 6 or 7 months, but do give it a shot. I have seen questions on this before. I think I remember getting a question on this as well. And the questions are pretty simple. They're just like, at this age, what do they have? Or when will the stepping motion be completed? So at 6 or 7 months, that's when we have a stepping motion. 12 to 15 months, the child can independently walk. Fine motor skills usually happen at 4 months, such as clumsy reaching at 4 months. 5 months, we'll have a coordinated movement with our 2 hands. Around 2 to 3 years old, we can use zippers but not buttons. And 6 years old, around when we get to school, we can start tying our shoes. Handedness, this is an interesting one, that around 2 years, we can gain our hand preference. Around 1 year, we can grasp things with our right hand. And that's because most people are right-handed. So that's where the preference comes from. And then hearing, the important thing to note here is that this is in comparison to adults. So 6 months, we have the same ability as adults to distinguish pitch in people. And at 7 months, same ability to locate direction and distance. And then again, with seeing as well, the same visual acuity as adults by 1 year. So yeah, I'd try and memorize this table or this slide. Okay. What reflex causes a baby who's being held upright by an adult and then is moved forward to begin stepping rhythmically? Yeah, pretty easy, right? It's in the question, stepping. But this is sort of what you would get for these reflexes. I have seen a question about the origin of the reflex or the significance. So that would still be an important thing to memorize. Okay. Let's have a look at the next question. A newborn baby, 1 minute after birth, receives an AGPA score of 4. What does this signify? Yeah, needs special attention. That's for sure. Pretty self-explanatory there as well. Which of the following ones is correct? So seeing a bit of variety, mostly D's, a couple of other ones, and yeah, D is correct. So hand preference, that's by 1 year. Let me quickly check something actually. Clumsy reaching is 4 months. So again, the difference is like small, so it's hard to memorize at times. By 2 years, we have the same visual acuity, that's actually 1 year. And yeah, we can distinguish between pitches as well as adults by 6 months. Okay, moving on to childhood. All right, what are we looking at here? So basically the first thing is social development, and we're looking at the caregiver behavior. So this is development that occurs due to behaviors or interactions between children and their caregiver. So what is mutual gaze? Again, in the name, eye-to-eye contact. We prefer to look at faces over shapes. Didactic synchrony. That's basically the parent reflecting behavior back to parent reflecting the child's behavior back, and that leads to that matching and that mutual attention. Conversation, motherese. That's the way that parents talk to their children, or baby talk, as you might have heard it, and that develops the capacity to take turns in conversation, essentially. And then social referencing. This is basically when a child or infant looks at the parent to guide their emotions on situations that they're not aware of. And that helps to inform their actions in the future. Okay. Now let's look at other factors that will influence play. So play is a big part of being children, as I'm sure we're all aware. The important thing to note is the factors that impact how we play. So make-believe, we know, is playing with roles that reflect our values and traditions. And it's exploring topics that frighten us, and also promotes imagination, sociability, creativity. To note is also gender differences in play. So when you're at 2 to 3 years old, you'll prefer to play with your own gender. There is something that is included in previous years, as well as this year, so about how the genders like to play. For example, there's a theory that boys will play more competitively against each other, while girls will play more supportively together. But again, it's pretty stereotypical, but just be aware that is something that they do include in gender differences. Parental influences. Again, obviously our parents play a big role in how we play, whether that's helping us in activities and like playing with us, or whether that's, settling any disputes and conflicts. The same thing with caregivers. If we have a fight on the school playground or an argument, obviously they'll play a role in determining what's right. The important thing to note is that children whose parents engage in these activities are often more socially skillful, and so a lack of that engagement can lead to undeveloped sort of social skills. Timeline of play. This is pretty important to note just at what age play changes. So around 1 year old, that's when we start to play, but we're not really playing together with other people. We're just playing on our own. And so there's that lack of interaction. At 15 to 18 months, we gain that interaction. We're doing similar activities, but we're not doing the same activity, essentially. We're doing it on our own, but we are interacting. So it's smiling, just playing together, but acknowledging each other, essentially. And then finally, at 2 years old, that's when we engage in cooperative play. That might be like playing certain roles and interacting in certain ways, right? So by roles, what we mean is like a role in a game, essentially, right? Like cops and robbers, for example. Someone is a cop, someone is a robber. Although I reckon that's maybe a bit too old for 2-year-olds. Attention and memory. So it's important to know how memory develops. I think the main thing to know in this slide is the ages that represent development of memory. So memory does begin at birth, but it improves obviously as we go from birth. So by 5 months, we can form memory of faces that last up to 3 months. And then by 2 years old, we can form a complex and relatively durable memory. Why do we do this essentially? So with memory, we can see stimuli, but we're unlikely to know it after a few seconds for newborns. There is something as well that is important to look at with memory, which is the idea of infantile amnesia. Basically, infantile amnesia is a paradox. It essentially says that although our earlier memories are really, really important for our for our lifespan development, we can't remember them. And so it's a paradox between the importance of those and the fact that we can't actually remember what happened when we were that young. And that's due to the fact that we see stimuli, but we can't really memorize them beyond a couple of seconds. On the left again, attention is just attention. What is attention? Specifically, it's when the information that we receive in our senses is actually comprehended, and we undergo some cognitive processes to understand it or to look at it, right? So that's what actual attention is. Orientating response, it's our reactions to unfamiliar stimulus, and it'll alert us to danger. Over time, we'll become, I forgot the word for it, but it's like habit. I don't know the word for it, but like we'll become accustomed to it, and our reactions will lesser because we'll know that that stimuli is not dangerous. Habitual, almost. I forgot the word. It's like acclimatized. That's what I'm trying to say. We're getting acclimatized to that stimuli, or it does become habitual. Yeah. It is a process of habituation. Our reactions will lessen to stuff that we've seen over and over again because we know it's not dangerous. But as a kid, we see a vacuum, first time seeing a vacuum, we might think of it as something incredibly dangerous, and our reaction might be really emotional and really physical. At the 10th time we've seen our parents do the vacuum, we should be pretty okay with that, or maybe more than 10. All right. looking at Carey's conceptual change theory, what's going on here? Essentially, this is looking at the way that this is looking at cognitive development, and it emphasizes the role of experience in that development. So before 6 years old, or 6 to 7, our cognitive development is all based on intuition. So understanding is it's not based on any internal biological processes or any internal processes. So we see causality just intuitively, right? So as an example, if we hear our tummy rumbling, we're going to think that it's more because the tummy wants to eat, not because we are hungry. So we're not recognizing that internal biological process. After 6 to 7 years old, we see the mechanistic explanations for these processes. So we realize that it's not our stomach that's hungry or our stomach that eats, but rather that we want to eat, and that's just our stomach digesting that food. So there we can differentiate between what's biological, what's psychological, and we can come up with that relationship properly. Understanding of death. So this is a very important part of childhood development, and I think it's really important to be aware of how children deal with death. And I think in my experience, at least, they're some of the harder questions to respond to. So what do we need to know? If we look at understanding death, there are 4 subcomponents. We have to understand that death is universal, it is irreversible, inevitable, and that there is some causal relationship between death. So if we go back to Piaget's cognitive development theory, at different stages, we're going to understand these subcomponents differently. And our sociocultural factors and emotional factors will also influence how we see these. So if we look at age before 10 years old, we're not going to have any coherent understanding of death. We're going to think about it as going away or going to sleep. We're not really going to be able to understand what's happening. So on the right here, we have a little guide for what death is understood at different stages of life. So at 2 to 7 years old, in the preoperational stage, we see death as being irreversible and something that must have a cause. Something that death must have a cause. So as in, we don't just die of old age, we don't just go away. Something must have caused it. 7 to 11 years old, at operational thinking, we begin to understand that death is final and universal, but we have these really strong reactions. And then 11 plus, at the formal age, we see that death is intrinsic to life, i.e. we gain that inevitability understanding, and we gain understanding that's similar to adults. Okay, so trying to apply some of those ideas, let's have a look at this question. Oops, sorry. Just trying to get the chat up. All right. Okay. So, what do you guys think? These are the trickiest questions, and these are some of the trickier questions in my opinion. Yeah. So not many responses, but let's go through it because we're sort of running out of time. Our answer is D. Why is that? Well, let's go back to this slide to understand death. At 2 to 7 years old and preoperational, we see death as reversible. So I think, can I play with Bunny later? That's sort of implying that death is reversible. So that's preoperational. I think Bunny is just sleeping. Again, that's not understanding what death is. It's in the preoperational stages as well. I think that the hard part is differentiating between C and D. Which one represents a proper understanding of death? Now, I base this on a question that we did get sort of at the end of last year from the HLSD department. And essentially, C is seen as more of an emotional response. And it's seen as something, it's seen as more to fit into the operational stage. We're not understanding that it's intrinsic to life. Whereas D is more of a mature response. They're sad because they won't be able to continue to do things with their bunny that they enjoyed. But yeah, I don't think the distinction is very clear in these questions. And so you do have to base your response a little bit based on your own intuition. So I would think the difference between concrete and formal is both the emotional part of the response, as well as which one just sounds more mature. All right, this next question. Yep, so this is going to be B. We're looking at our caregivers or our parents for an indication of how we should respond. That's exactly what's happening. Okay, let's move on to the adolescent stage of development. Puberty. This is pretty important. What is most important? I think looking at this brain development system, limbic system, that's the system that gives us our rewards. So at puberty, that part of our system matures and we're able to want to reward ourselves. We're able to understand the concept of rewards. But our self-control area, or our prefrontal cortex, is still immature. And that's what leads us to do a lot more risky things. Because we want to do the thing that's enjoyable, we want to reward ourselves, but we don't have the self-control or the understanding as of yet to be able to do that properly. What are primary sex characteristics? They are your genitalia, essentially, the things that are directly involved with reproduction, as well as your internal sex organs. So they develop pretty early, but we do see some development in puberty, which is maturation, for example, of our primary sex characteristics. Secondary sex characteristics, those are the physical signs of maturity, but they're not actually linked to our reproduction. For example, pubic hair, facial hair, the growth spurts that we undergo in puberty, those are the secondary sex characteristics. This is not too important. It just says what factors contribute to teenage pregnancy, but they're pretty obvious as well. Ignorance, illusion of invulnerability, which is again has to do with our limbic and prefrontal cortex system, and then lack of motivation and access. This is something to remember, and it's something that we might oversee when thinking about teenage pregnancy. But a lack of access is also key, right? A lack of access to contraceptions, a lack of access to education as well. Okay, gender and sexuality is a really important part of the course. We have some definitions here. I won't really go over them as we're pretty comfortable with these definitions now, but just remember that these definitions might not be very universal, but they are the ones that work for HLSD. So just being comfortable with what these words mean in the context of HLSD. Something to note is that there is a conflict between, there's a conflict in medicine with the idea of delaying transition. So a delayed transition would lead to a greater amount of time with gender dysphoria, but there is also a point that delayed transitions might reduce the risk of stigma and bullying. I don't think this is that important in terms of the HLSD questions, although it is an important clinical point in our gender and sexuality development. Okay. Developmental differences. This slide's here for more of a sake of completion. All it says is that injuries and differences in our development can lead to impaired functions in cognitive, social, and motor sensory departments. And we will look further at developmental differences, but where we look at them specifically is in terms of ERIC and psychosocial stages. So this is looking at a little bit deeper dive into what these stages are. So again, let's just go through the conflicts of each of these stages, but I'll leave you guys to read through the issues on your own. So birth to school, our stage is trust, mistrust, autonomy versus shame, initiative versus guilt. Childhood, that's industry versus inferiority. Basically, we're trying to be gaining some independence. We're trying to, play on our own, expand our abilities, but we're not essentially capable of being fully independent yet at that stage. In adolescence, that's about determining who we are, all about our identity, and that continues on into young adult, the same sort of stage of development, but the issues are a little bit different here. The issues over here is in adolescence is gaining your independence, forming your social relationships, whereas in the young adult, it's more about the growth, right? About educational, vocational employment, your goals and your opportunities. Your adult stage, intimacy and isolation, so that's your relationships, and the generativity versus self-absorption, that's about leaving something for the future generation or just contributing to the broader society. And then your final stage of aging, integrity versus despair. This is essentially like introspection. Are we comfortable with what we've done, or are we sort of not happy with what we've achieved? Okay, so one important thing to mention quickly before we look at the question is that when we're trying to intervene or look at developmental differences, our aim should be to sort of restore or to address these conflicts, right, in each of these stages. So in this next question, try and think about the conflicts that's going on at the age of this patient and which one of these interventions will best help to address that conflict. Anyone have any other ideas? What are you guys thinking? C. Any other suggestions? You can see those are, I think, good ones to cut it down to. The better answer here would be C, support for Ken to attend the school dance. Now, why? If we go back to this sort of adolescent, young adult stage, we are forming our social relationships. And so if we look at the school dance, it's going to help form that social relationship, help form the identity the most. Speech pathologists with communication assessment, that's not going to help the identity and belonging. Weight reduction, again, that's not going to help the identity and belonging. I think the reason why we choose C over D is that a carer to take Ken to the movies will not necessarily give him identity and belonging. And it depends on the carer itself, because that carer might not provide a social relationship, just that relationship of care and caregiving. So sure, Ken will be able to watch a movie, but that doesn't help the identity and belonging part of Ken necessarily. Okay, I think there is an issue here because that is not the question that I was meant to ask. But essentially, what we're asking about here is, why do teenagers take risks? If you remember, the limbic system will be mature because we see a lot of reward, but we don't have any self-control to limit that reward. And so our prefrontal cortex is immature. Sorry about that. I'm not sure where that question has gone. Okay, moving on to adulthood, does the hypothalamus play a role? Whoops, let me go back. So the hypothalamus is pretty important in terms of our endocrine system. It signals what we're going to release. The hypothalamus is more important for puberty. So when the hypothalamus starts firing a specific hormone known as GnRH, that's when our sort of puberty process starts and continues. So it is relevant, but it's not as relevant to what we learn in HLSD. If anything, just remember that the hypothalamus is responsible for puberty in general. So it's not going to necessarily deal with risk and immature in that part of our system. Yeah, exactly. Not as much important for social development. It is important for initiating puberty, but not for our social development. That's a good way of summarizing it. Okay, let's go into adulthood. I might go a little bit faster through some of this. But again, I think most of the information is on the slides, and the slides is probably a great way of revising as well. So if we do go over anything fast, sorry about that. So adulthood, again, three themes of, not again, first time we're looking at this, three themes of friendship, affective versus emotional, shared / communal nature, and sociability and compatibility. So essentially in our friendship, we need these three themes in order to be successful. We need some shared interest. We need to be compatible in our sources of fun and our entertainment. And then we also need to be able to express that intimacy, appreciation, and support in similar ways to each other. So how do friendships develop over these 5 stages? Which is pretty intuitive, right? First, we're acquaintances, friends build up, we continue our friendship, and then sadly, but unfortunately, friendships might deteriorate and end. So it's, sort of like a little build up and then a fall. So a side note that is important to know is that connectedness in men declines at around 35 to 54 years old, and that relationships among men are often more based on a common interest. And so when that common interest ceases, that friendship also does. And there is also a risk of illness, disability, and unemployment. Those are associated with a higher risk of poor social connectedness. So something to just be aware of. Love, similar to friendship, we also have components for love. That's passion, intimacy, and commitment. Essentially, the idea here is that at different stages of our relationships, we'll have a different combination of these components. So at the start, we'll have a lot of passion, a lot of intimacy, but not a lot of commitment. As the relationship goes on, the intimacy and passion might reduce, but the commitment will increase. Also, something to note is that relationships that are characterized by infatuation or a lot of passion are more likely to fail. There are higher rates of divorce, and that's because the intimacy and commitment might be a bit lower. And then again, these other two things, just be aware of them. Not too key. Yeah. Violence in relationships. This is just acknowledging the types of violence and abuse that will occur in a relationship and what the cause for those relationships might be. It's not too important in terms of HLSD and the questions you'll see. I don't remember getting quizzed on any of this, but just be aware of aggressive behavior and how it progressed. It'll start verbally, it'll go into physical abuse, it'll become severe physical abuse, and eventually it can progress into a murder or homicide, right? Obviously, not every aggressive behavior will progress all the way, but it is that slippery slope of aggressive behavior that can quickly turn into something bigger than what it started. As well, important to note is that women in violent relationships will report higher levels of physical and emotional problems. That's because physical violence has an emotional toll as well. Okay, let's look at some adult development theories, specifically looking at work. So work has a lot of purposes. Firstly, Holland's theory is essentially saying that we pick a career path that fits with our personality traits. And our personality type will influence our choice of occupation. Pretty intuitive. Social cognitive theory, again, that's Bandura. That's talking about how we learn from others. And that the relevance here is these 6 variables that impact our employment. So interest, again, similar to Holland's, choice goals, similar to Holland's, but also important is the support and barriers, right? If there's a lot of barriers to receiving, or if there's a lot of barriers to getting work and getting employment, then of course we won't be able to get it, such as your socioeconomic class, status. Those definitely do play a role in what job you get. Unemployment, again, not too important. I don't really remember covering this in that much depth. Just do know that unemployment has increased risk of suicide, more in the uneducated, and it can be associated with poor physical mental health. That could be more of a correlation than a causation as well. That's there. And then the factors that lead to unemployment. Okay, this is probably the bigger part of HLSD, the psychopathologies. So first up is the model of psychopathologies. So Freud sort of proposes that there's 3 parts of our mind: id, superego, and ego. Id is the part of our mind that focuses on pleasure. Superego is the part that focuses on the values that we learn from others. And then ego is how we balance those two. So a conflict between id and superego can cause anxiety. And that will lead our ego to using defense mechanisms to cope with that. So yeah, it's all about the balance between id and superego, which we call ego. Multifinality versus equifinality, it's just in the name, multifinality. One event will lead to many different things in different people. Equifinality is the same thing will lead to many same things in people. So we'll have a question on that later that explains that point a little better. Social cognitive, again, we talked about that a little bit before. We learn our behaviors among others. Social cognition is thinking about how others think about us, how we think about ourselves and our relationships with the people around us. And distortions in this belief can impact to psychopathologies. Classical conditioning, again, we talked about Skinner's conditioning. Now we're going to look at classical conditioning. Essentially, this is where we have a unconditioned stimulus that we pair with a neutral stimulus, i.e. a stimulus that doesn't cause any reaction. And then by pairing them together, the person or the dog will associate the neutral stimulus with the unconditioned stimulus, and that will mean that the neutral stimulus essentially becomes the conditioned stimulus. It will cause that response to the unconditioned stimulus. So that might have been a bit confusing, but this dog picture really helps to understand it. We have something that we don't really react to other than innately. When we see food, we salivate because we are hungry. That's our body process. When we see a whistle, we have no reaction. And so when we see them together, we're still salivating, but that's because of the food, right? But over time, if we associate that whistle with a food, we'll begin to have a conditioned stimulus because a whistle doesn't cause anything innately on us. It causes something over this process over time. Okay. And then just a small sub point here that genes do play a role in our risk for mental illness as well. And the neurotransmitters is the link, as in how genes can give us greater risk. Okay, so here's another question. I'll give you guys go through this. These, equifinality. They have different events, but they lead to the same result. That's a pretty good example of that. Okay, let's look at the conditions. I think from here on out, these are really, really important things. So make sure you're pretty comfortable with the broader ideas. I'll highlight what is most important. Psychopathologies, it's just definitions here, really. I'm going to continue. ADHD, the next few slides have a lot of information. And since we're over time, I'm going to leave this up to you guys to review. I don't think it's important to memorize every bit of it, but just be comfortable with what ADHD is and what these conditions are, and understand how to manage them a little bit. But you definitely don't need to memorize everything on this slide. Same with delinquency. This was pretty minor. I don't remember getting any questions on this. And schizophrenia, a bit more important, but again, a lot of information. Just understand it generally, as in what schizophrenia is, and sort of how to treat it. A good point here is what's the difference between a hallucination and delusion? Delusion is something that seems real to us, a belief, essentially, but hallucination is when our senses are stimulated without any actual stimulation existing. Okay, personality disorders. I'm going to skip this slide. So these clusters are really, really important. Cluster A, cluster B, cluster C. I would basically memorize these slides, know what each of these disorders are and how they fit in under cluster A. So A is schizophrenia. These are stuff that is like paranoia, essentially, right? But that's an oversimplification for sure. Paranoid personality disorder, in the name almost. Schizoid personality disorder, that's detachment from relationships. Schizotypal personality disorder, that's being uncomfortable or in those in close relationships as well. Cluster B, dramatic or psychopathic continuum. Antisocial, in the name. Borderline is an inability to continue relationships. It's about your self-image and impulsivity. Histrionic, again, that's something that's not very obvious. So that's about attention seeking, excessive emotionality. Narcissistic, pretty much in the name. So we do look at borderline a little bit more specifically here, but just like the other conditions, I'm gonna let you guys review this on your own. Not too important. These factors, definitely don't memorize them, but just have a general understanding of what borderline is. Cluster C, anxious, that's neurotic. Avoidant, in the name. Dependence, also in the name, really. And obsessive compulsive disorder, would be pretty generally aware with all this is just anyway. Anxiety, I think it is important to think about what anxiety can arise at different stages of life. Childhood, separation anxiety, as well as phobia, there's a lot of fears. Late childhood, social phobia, right? We're scared of others. Social environment is something that scares us. Adolescence, that's when we gain panic disorders, generalized anxiety, and then again, similar in middle adulthood. Okay, causes, not too important here, really. All right, So talking about suicide, I think the important part to take away from this slide is the 3-step development of suicide. Ideation starts due to some psychological pain or hopelessness, and that is exacerbated, and then eventually that ideation may turn into an attempt. And these sort of factors will be playing a role in prevention, essentially. But nothing really to memorize too much from this slide. All right, let's do some questions. So B's, yep, that is correct. So the other ones are listed there: avoidant, neuroticism, and histrionic. Okay, so I know I said not to memorize everything for schizophrenia, but they could ask you stuff like this. But again, it's a lot of information for not a lot of questions, essentially. But I'm seeing D's. Yep, that's perfectly right. C is very much a misconception. And A, it is not really determined by environmental factors, more by genetics, or yeah. All right, dependent personality disorder. Yeah, so this one is C, and need to be taken care of. Again, dependent, right? We're dependent on others. That's our personality disorder.
Bhuvan.
Yeah.
Which one was B? Like, which disorder would B be?
Which one? What do you,
like
do you have a
sensitivity to
guess?
negative. I was going to say borderline, but
Borderline. So let's have a look back at our clusters, right? So I think
what's
it
avoidant?
was. Yeah. Sorry. Yeah, it is avoidant. So yeah, we avoid criticism essentially there. But yeah, they're more likely. Yeah, these are pretty word for word in terms of these questions. And like in the questions that we got from the HLSG department, they were similar to this last year. Not in the exam, but just like in like practice stuff that they sent us. All right, aging and dying. The next slides like have a lot of information. I don't think it's like feasible really to memorize everything, but having an understanding is really important. Normal aging, again, just how we age. Body system changes, a lot of body system changes. You cannot memorize these. You shouldn't memorize these, but a lot of them are really logical. I think just have a read through of these in your own time, just so if you see them again, you might be able to know them. But yeah, they're mostly pretty obvious. Dementia, we have a couple of different types of dementia: Alzheimer's, vascular, mixed, and it's characterized by decline in memory, learning, confusion, changes in our personality and behavior. How do we diagnose dementia? It's hard to diagnose, but it is clinically diagnosed. So I'm not sure exactly why I wrote in here. It's only able to occur post-mortem or definitively, because you cannot come up with a definitive definition for that. Treatment, there's not much treatment. Important considerations to make is end-of-life care. Who's going to make the decisions for the individual once they lose their capacity, and can they drive? At one stage, they probably should not drive with dementia. Delirium, again, I'll leave this here for you guys to go through. This diagnostic test is probably something to be aware of, but I don't remember paying much attention to this last year. Depression, this again is talking about the depression screening test. There's 5 questions. If you answer no to the first one, that's positive, and 4 to the last 4. Sorry, yes is to the last 4. Again, that indicates depression. Frailty, as we old, we get more frail. So what's a clinical definition of frailty? We just have to have 3 or more of these criteria: shrinking, poor endurance, weakness, slowness, low physical activity. Definition of that, this is more important. I have seen questions where they ask you, what defines what part of this defines brain death, what doesn't. But again, it's pretty hard to memorize all of these. Just be aware of what constitutes whole brain death, how do you determine brainstem function, as well as how do you determine death on the ward. So yeah, these are things that they can ask, and they have asked, and they're very annoying question because they'll give you like 5 things and they'll ask what one of these is not involved in determining death on a ward. Stage of dying is pretty important. It's just how we deal with death. We might not go through all the stages in this order, but we might not go through all the stages in general either. And we might get stuck at stages, we might go back. But essentially it's denial, anger, bargaining, depression, and then acceptance. Grief is really important. I think the main thing here is anticipatory grief, which is just that we might understand a loss or come to our loss ahead of time. For example, if we are dealing with the loss of someone who has cancer, we might accept that their passing is to happen. And morbid grief is when that grief can go on for really long. Types of death, that's sort of what I was talking about before. Expected or prolonged with a cancer. Sudden, that's something that's more likely like an acute event. Sudden and expected is like if someone has cardiovascular disease, we'll expect a heart attack. That's sort of expected. Unexpected, accident, right? Those are just completely out of nowhere. Okay. Advanced care planning, not too important. Essentially, we can make advanced care plans that tell clinicians what we want to happen to us if we are not able to make those decisions on our own.
Bhuvan, I have a question about these.
Yeah.
Are they legal documents or not?
Yeah, so advanced care plans themselves are not legal documents. They're a plan within itself is not a legal document. It's just saying this is what I'd like to happen. You'll see these a lot in aged care homes where they have advanced care plans, and aged care homes will follow them because those are the wishes of the patient. And they usually have some sort of like policy of following them. Advanced care directives, those are legal documents, and that basically places the planning in a legal place. It gives it a legal way, and so it will be prioritized above a surrogate decision maker, but it might also specify a surrogate decision maker to make decisions.
So like all these directives, the instructional and values are both legal, are you saying?
Sorry?
All the directives, the instructional directive, values directive, that sort of stuff, they're all legal, right?
Yeah, so for our advanced care directive, they will be legal. Yeah, these two directives. But again, some of it is hard, right? Like you'll talk about this more in ethics. Like, if I instruct someone to say, never let me die, at what extent, is that followed? But that's not too much in the scope, I think. Main thing is just knowing that there's advanced care directive with 2 types of sort of directives, instructing what's to happen, and values, right? Values are important to me. So there's more abstract ideas like I do not want to, like for example, someone might say that if I'm at a stage of dependency, then that is something that I would not like, or I do not want to be dependent, for example. That's sort of values. Hopefully that helps.
Yep, sounds good.
What are the benefits? Not too important. Voluntary assisted dying. I think note what you need. Note the criteria that allows you to access VAD. Australian citizen above 18, having capacity, and importantly, is the last criteria. That's a big one. About a condition that will cause death in under 6 months. So voluntary, the doctor cannot suggest or initiate this discussion, and it must be requested 3 times, approved by 2 doctors. So it's a lot of like checkpoints. There is a difference between voluntary assisted dying and euthanasia. Voluntary assisted dying, the patient will take the drug that causes the death themselves. Euthanasia, the doctor will administer it. Okay, so our final question for HLSD slides today is this. See, yeah, anger is not included. The rest are, which is interesting because you would think that logically it makes sense, but in the Kluber-Ross model, it does not. Okay, guys, So that was, I know that was a bit fast, and there was a lot of content that we just ran through. But HLSD, it's not too bad, and if you have an understanding of sort of the general ideas, you can definitely figure out a lot of the questions inside the exam. So yeah, good luck with HLSD. And also, I think we'll be taking a break now until 2 o'clock, but we'll come back for cardio phys. So I'll see you guys all then.
All right, are we good to get started? Luffy?
Yeah, all good.
All right then. Hi everyone. We're doing cardiophysiology today. So I guess cardiophysiology is one of those topics where you really want to know the concepts, right? A lot of the specific details, they won't really test you on, and it's probably not that important, but a lot of the relationships, specifically when it comes to like the pacemaker cell currents or the pressure and flow relationships and stuff, you really want to know the overarching concepts. Also, if I'm going to try and make this as interactive as possible, so if you go all just get your chats up, I've got my chat up, and as I ask questions, if you just put it in the chat, the more you put in, the more you'll get out of it. If you want, you could just DM me. That's all right as well. I know you guys have really recently learned this topic, and cardio probably went by really fast the past few weeks, but also that just means that it's more fresh in your brain when for the exams. Okay, here's my email. Here's my Facebook Messenger. All right, let's get started. This is a table of contents. We'll start with some vascular physiology, then into the heart stuff, and then microcirculation. And then I've got a bunch of questions at the end. And here are my sources. Okay, starting off, vascular physiology. Overall, again, concepts. You want to know that there's two major circulatory systems. You've got your pulmonary circulation, which is starting here in your right ventricle, all the way out, pulmonary trunk to your lungs, back in through your pulmonary veins, and ending up in your left atrium. There's the full path. And then you've got your systemic circulation, which is starting off in your left ventricle over here, going out through your aorta, providing all your systemic capillaries, so your head and neck, your abdomen, your upper limb, lower limb, and then coming in through your superior and inferior vena cava into your right atrium. And there is the full path. Okay, but what do you need to know about these systems? You need to know these three main things, okay? The pressure, volume, and oxygenation. So starting off with our first question, which system has the higher pressure? Pulmonary or the systemic? Just pop it in the chat. Nice. Systemic. Perfect. Systemic, which makes sense because you want to get all this blood out to much further distances to your feet, to your head, and all that. Whereas the pulmonary circulation, you're just trying to get to your lungs, which are right next door. Which system has more volume of the blood? System has more volume of blood. Okay, I'm getting some mixed responses between systemic and equal. So they do have the same volume of blood, which kind of makes sense if you think about it, because all the blood that's coming into the heart from the vena cava or from the pulmonary veins needs to get out. And so all the blood that's going to your systemic capillaries will need to be oxygenated. So all that blood has to go through your pulmonary circulation. And so when that gets mismatched, so when there's more blood entering into the body through the systemic circulation than going out to your lungs, that's when you get things like congestive heart failure and different pathologies. I've got a question here. Isn't the volume the same, but the flow is equal? So the volume is the same. And we'll be talking about flow because flow also incorporates pressure and resistance. And so those variables make it different. And whereas oxygenated and deoxygenated blood, that's pretty simple. You just, anything after the lungs in the left side of the heart and before all the capillaries will all be oxygenated. Anything after the capillaries where your body's using it and metabolism's happening and all, and before the lungs will all be deoxygenated. So the blue and the red. So right side of heart is deoxygenated, left side of heart is oxygenated. Okay, components of the circulatory system. So we go arteries to arterioles to capillaries, and coming back, we go capillaries to venules to veins. Some more questions. Which of these act as a reservoir of blood? Nice. Okay, veins. That's good. So veins, if you remember, have thinner muscular walls, so they are more distensible or more compliant, which we'll talk about later as well. But essentially, they can expand more, and so they hold a lot more blood, and that's why they're acting as a reservoir of blood. So most of your blood's actually in your veins, which functionally acts as the primary control of blood pressure. Yeah, nice. Okay, arterioles. So arterioles are essentially just before your capillaries, and there's a bunch of different mechanisms and theories as to how they control blood pressure, which we read towards the end of this presentation. But arterioles essentially provide the most resistance, and they are the main controller of blood pressure in the acute system. Which component has porous walls? Yeah, good. Capillaries. Capillaries make sense because that's where you want all your oxygen, your nutrient exchange, your waste products to exchange. So you want your blood to freely leak in and out of your blood vessels. All right, this is just some more information about each of these parts. What you need to know, the main concepts are arteries have strong vascular walls, so they're very thick muscles. The arterioles control your resistance. Capillaries are porous, and that's where all the exchange happens. Venules, there's nothing important about them. But they're basically mini veins. And veins are your reservoir of blood because they have thinner muscular walls and lower pressure. Okay, now this concept of pressure, flow, and resistance and how they're all interchanged. So there's a bunch of formulas. Essentially, these two are the main ones you want to know, and you can rearrange them and figure out a lot of stuff. So essentially, Q is flow. So change in pressure equals flow times resistance, or your mean arterial pressure equals your cardiac output times your TPR. And so you might remember there are other formulas for all of these, such as mean arterial pressure is also your 2/3 plus 1/3 of your systolic diastolic. It's later or cardiac output equals venous return. And so you can, if you are given different factors, essentially you want to know the relationships to all of these things, and then you can input whichever equation works well. I don't know how you guys will do this without any paper, but you can type it out on the little notes. Why do we care about pressure? Okay, so we talked about we have pressure, flow, and resistance. So first of all, we're starting with pressure. Pressure determines your flow through a vessel. So it's kind of like a similar concept to osmosis and stuff, where the more you have essentially what your blood's going to go from higher pressure to lower pressure. And so the larger the pressure gradient, the more blood's going to flow. So it's a proportional relationship. Also, pressure is important within the heart. And so when we talk about valves, right? And so if in front of a valve, if you have higher pressure in front of a valve, the blood's exerting pressure onto the valve over here. And so the valve's going to close. Whereas if you have more pressure behind the valve than in front of the valve's going to open. Because I mean, these are 3-dimensional spaces, and so the blood is like pushing out in all aspects, and all around it. What primarily creates this pressure gradient? When we're talking about vessels and stuff. Okay, so a few options here. Essentially what you want to know is the pumping action of the heart provides the pressure going out. And so resistance and stuff like diameter will change the pressure after into the vessels, but the primary creation of this pressure gradient is the pumping of the heart, which pushes the blood out. Okay. Next up, we have flow. So we already talked about pressure and flow being proportional. Flow is then inversely proportional resistance, which this is just the earlier formula just rearranged. So now we have resistance in the denominator, which makes sense because it's inversely proportional. And so the more resistance you have, the less blood is going to be able to flow through it. Now, whenever we talk about flow in these equations, we're referring to laminar flow, which is essentially, if you think of a vessel like a cylinder, blood's just flowing through it without anything messing it up. And so turbulent flow actually stuffs this whole thing up, and these formulas don't apply. And so could you guys tell me any causes for turbulent flow in a vessel? Nice, exactly. So there's a few things coming into the chat, which are pretty much atherosclerosis, which is the plaque building up with hypertension and stuff. Stenosis, which is the vessels essentially shrinking down a bit, or in the valves where there isn't, where the valves don't open enough to push blood through. And regurgitation. These are all, pretty much things that cause turbulent flow. And how can we hear turbulent flow? Exactly. So there's a few things. There's either auscultation or murmurs coming up. So you hear it with your stethoscope, pretty simple, by auscultating the heart. And then when we hear turbulent flow, we call those murmurs. Also, another interesting cause of turbulent flow is actually an aortic dissection where the aorta, there's like this false lumen that tears open, and you'd probably hear a murmur as well. Heaves and thrills are similar. I think the main difference is like how you hear them. And so one of them is like if you just place your hand on top and you feel, I think that's a thrill. I'm not sure. But they're all very, very very, very similar terms. Probably your clin skills thing will probably differentiate. Okay, resistance. Continuing on, what are your 3 determinants of resistance? Just the 1 or 2 or how many? Yep, exactly. So, So we start off with viscosity, which is essentially your hematocrit, or how thick your blood is. Not really tested that often because there's not much that changes it, but that's proportional. So the more viscous your blood is, the more resistance there is, the less flow there is. The length of the vessel, which is also proportional. So the longer the vessel, the more resistance there is. They do test this sometimes. They'll say like a 10 centimeter vessel versus a 15 centimeter vessel. So the longer vessel will have more resistance and thus less flow. And lastly, the radius of the vessel, which is inversely proportional. So the smaller the radius of a vessel, the greater the resistance. Which of these has the greatest impact on resistance? Exactly. Yep. Radius, diameter, all of them. And so, So resistance is 1 over radius to the 4th power. This is a simplification of some crazy formula you guys probably got in a lecture as well. But essentially it's to the 4th power. So if you halve the radius, that's 2, 4, 8, 16 times more resistance. Ooh, Frank-Starling law. Okay, I like this law. Essentially, the Frank-Starling law is a very fancy way of proving that cardiac output equals venous return. And how that happens essentially is, I think of venous return, what's that referring to is the blood coming into your heart from like your superior and inferior vena cava into the right atrium, right? And what the law is saying is that that's equal to cardiac output, which is the amount of blood that the heart's pumping through. So essentially, blood that's coming in is equal to blood that's going out. And that's the most basic level of understanding. The next level would be how that happens. And so that would be essentially, if you think of the heart, it's a muscle, right? And it's got these chambers, these closed chambers surrounded by muscle. And so if there's more blood coming in, these chambers are going to have to expand, right? The muscle is going to have to relax a bit more to accommodate this extra blood that's coming in. So more blood that comes in, the more stretch there is on the actual cardiac muscle. And if you think of cardiac muscle like an elastic band, and so the more you pull it, the more you stretch it, and when you leave it, the faster it's going to come back together. And so when there's more blood coming in, when there's higher venous return, those cardiac muscles, myocytes in the ventricles, get stretched out a bit more. And that means when they do eventually contract, they contract harder, thus increasing your stroke volume and your cardiac output. And so then the next level of understanding, I don't even remember this much, but there was something with actin and myosin where the more stretch the muscle is put under, I think there's more overlapping of actin and myosin, but that's your next level of understanding. You can read into that more if you want. And then this next formula looks daunting, but it's essentially to calculate venous return. And if we simplify this, if we talk our way through it, so we have venous return equals the pressure in your blood vessels, in your systemic blood vessels, minus the pressure in your right atrium, right? So your blood is coming from the superior and inferior vena cava into your right atrium. So pressure in your blood vessels minus the pressure in your right atrium. What's that? That's just your change in pressure divided by your resistance to venous return. What's that? It's just your resistance. So, and venous return is kind of like flow. So it's kind of like flow equals change in pressure over resistance. It's basically the same formula. Now, what you want to know is the relationship though. So they may ask you if there's increased pressure in the right atrium, which the right pressure in the right atrium is essentially considered to be zero. It's considered to be negligible. And so if they do say in a pathology there is increased pressure in the right atrium, how's that going to impact venous return, or how's that going to impact cardiac output? And so increased pressure in the right atrium means this number is smaller. The numerator is smaller, so the venous return is smaller, which means your cardiac output is smaller. So just if you remember these formulas, you can reverse engineer, you can work your way backwards and figure out essentially anything in all these relationships. And so, yeah, and so this is just, if venous return, if this isn't equal, and so venous return is greater than cardiac output, essentially there's more blood coming into the heart than is exiting, that becomes what you know as congestive heart failure. And this is just an example that ties in a lot of concepts. So I thought I'd introduce it here rather than later as an introduction. So here we have Tommy, and he's on a run, he's trying to get more fit. And as he's exercising, muscles are working, so his tissues demand more oxygen, right? If they demand more oxygen, they're also using up more oxygen, which means they're going to get rid of all that blood with all the waste products faster, right? So as he's exercising, the venous return increases because you want to dump all that wasted blood back into the heart to get you oxygenated again. Now, according to Frank Starling's law, if venous return increases, then your cardiac output also increases. So Tommy's tissues are getting perfused more, which is why he might feel his muscles and they're hot after exercise. One of the many reasons, right? But essentially, you don't want this for too long. You don't want your tissues to get perfused continuously for that long. And so what happens is autoregulation. And so when you're exercising and when you stop and you're cooling down, your tissues undergo autoregulation, which constricts those arteries and arterioles. When you constrict arterioles, that's constricting the diameter. And so that's going to increase your blood pressure, right? When you increase your blood pressure, your flow increases and your demand for oxygen then returns back to normal because you're getting more oxygen. And that all goes back and your cardiac output is reduced. So this kind of ties in a lot of the concepts, and we'll talk about autoregulation more later in the presentation. But if we think about exercising, you can get a lot of the concepts with Frank Starling's law and venous return and cardiac output, as well as autoregulation and all the factors that are around that. And then also your arterial blood pressure. Okay. Another concept is compliance. It's pretty self-explanatory. It's essentially when the ability of a vessel to expand when pressure changes. And so compliance is essentially just change in volume over change in pressure. And if you just have an image of what veins and arteries look like, a vessel is more compliant if there's greater increase in the volume during an increase in pressure. And so if you think of veins, they have these thin muscular walls that are distensible and they're floppy and they can hold more blood. And so if you pump more blood into it by increasing the pressure, that vein's just going to expand and distend. And so it's going to increase its volume, which means it's more compliant, actually 24 times more compliant than arteries, because essentially they have less muscular walls. So you can think of this either way. So if you have a certain amount of pressure, a vessel that's more compliant, like veins, is going to have a greater change in volume, or for a given change in volume, it's going to have less change in pressure than a low compliant vessel. Yeah. Okay, that's all your vascular physiology done. We'll move on to the heart's electrical conduction. this diagram, pretty important. Know it, memorize it, do what works, put it in Anki, whatever works for you. Essentially, you're starting up here in the right atrium and you're spreading all the way down. Excitation spreads from the endocardium, so the inside of the heart, then to the myocardium, which is your muscles, and then to the epicardium, which is the outside. So it's going in to out. Here's your one slide summary on electrical depolarization. Let's walk through it. So we start up here in the right atrium. We have the sinoatrial node, the SA node, which is a pacemaker, and it spontaneously generates an action potential. This is your pacemaker potential, which has your funny current and all. Now, we need to get that current to the left atrium because we want both our atria to contract, and then we want our ventricles to contract. So we go through the interatrial pathway, also known as the Buckman's bundle, to the left atrium. Okay, now we have our right atrium and our left atrium. They're both depolarized. Now we want to go down to the ventricles. So via the internodal pathways, we then send this depolarization to the AV node, okay? And the AV node will then lead to the bundle of His, but over here, the depolarization slows down. Why does it slow down over here at the AV node? Any ideas? Exactly. So you guys have getting a bunch of different answers. You guys are essentially doing why and how. So why it slows down is to allow the atria to contract, so the ventricles to fill up, and so the ventricles contract after the atria, because you don't want everything to contract at the same time, because then there's not enough blood in the ventricles. So you want your atria to contract. That will cause your ventricles, all your blood to go to your ventricles. You want a bit of a pause. And then once your ventricles are full, only then do you want your ventricles to contract, right? If it slows down, then everything contracts all at once, which you don't want. And how it happens, which also people have been saying, is less gap junctions, exactly. So there's just less gap junctions, which means the electrical conduction can't travel as fast. There's also, I think, more fibrous tissue is another one of the reasons. Okay, now we've passed the AV node, and the depolarization spreading down the ventricular septum. This part is called the bundle of His, or your right, which then your bundle of His then splits into your left and your right bundle branches. And your left one actually depolarizes first, just a little fact to know. And I think that actually causes, because your left depolarizes first, it causes a little dip in your ECG. It just, based on the direction it's depolarizing. And then from your left and right bundle branches, then you go into the ventricles via the Purkinje fibers. Okay, I just got a question about how important the numbers are. Not at all important. I don't think they would ever ask you about the 0.03 and the 0.05 and all. I guess just know that the AV node is slower. That's all the numbers are trying to get through. Purkinje fibers. Yeah, so that's where we left off. The Purkinje fibers then spread up to the sides of the ventricles, and that's what causes your ventricle muscles to beat. And that's just your endocardium to epicardium. Okay, I'll just go through a bit. These slides just have a bunch more detail about each of the different parts. So SA node, locations in the right atrium. So ANS stuff, I have a better table later, but essentially your sympathetic and your parasympathetic nervous system. So your sympathetics are your noradrenaline on beta-1 receptors. So you remember your sympathetics act on alpha and beta receptors. So in your beta receptors, you have beta-1 and beta-2 receptors. You have one heart and two lungs. So the heart has beta-1 receptors and the lungs have beta-2 receptors. So noradrenaline on beta-1 receptors is your sympathetic innervation of your heart. Acetylcholine on muscarinic receptors is your parasympathetic, and that's via your vagus nerves. Now, your sympathetics innervate both your nodes, so your SA node, AV node, and also your myocytes, the cardiac muscle cells. So it increases both the heart rate and the force of contraction. Whereas the parasympathetic only innervates the nodes, so it only slows down heart rate. It doesn't change the force of your contraction. Um, so your sinoatrial node has an intrinsic heart rate of 100 beats per minute, right? So with nothing else, it's going to beat at 100 beats per minute. That's its pacemaker potential. And so in the absence of any sympathetic or parasympathetic nerve input, that's how fast your heart would beat. But our normal resting heart rate is 60 beats per minute. And so that essentially tells us that there is a vagal tone, which is essentially a constant parasympathetic innervation of the heart, which is your rest and digest. And that has a greater effect than your sympathetic. So it slows down your heart rate. Can anyone tell me an example of when this would happen? It sounds kind of dramatic. Why would you never, in which situation would you have an absence of sympathetic and parasympathetic innervation? Exactly. Heart transplants. Good. So heart transplants, obviously if you're cutting off the heart, you can't take the nerves with it, the innervations. So you're going to have to take off, if you're transplanting the heart from one person to another, they aren't going to have those nervous connections. Interestingly though, the sympathetics, the parasympathetic is only by direct nervous innervation, so the actual nerve fibers innervating the nodes, but the sympathetic both has the innervation, but also has circulating catecholamine. So you have circulating noradrenaline in the blood. And so that's still going to be there in the transplant recipient. And so even if you have a transplanted heart, you can still increase the heart rate because there's still catecholamines in the blood. AV node, pretty much the same table here. Purpose of the node is to relay the signal from the atria to the ventricles, which we talked about, so that the atria can empty their blood into the ventricles before they contract. Yeah. And then your AV bundle.
Yeah, John, I just have a question.
Yeah.
So did you say for SNS, there's receptors on both the muscles and node? That's why it can increase heart rate and force.
Yep.
Okay, thanks.
Yeah. Nice. Yeah. So your SNS it has both cardiac myocytes and the nodes. So it increases, your nodes are in charge of your heart rate and your myocytes are in charge of the force of contraction. Your AV bundle, which is your bundle of His, is essentially preventing your electrical signals that have come down into the ventricles from going back into the atria. Right? And so if you can imagine, if there's something wrong here, that can cause arrhythmias, because then your depolarization, the electrical impulses are going back into the atria, and that causes mismatch of the beating. And the left bundle branch is activated first, which we talked about. Yeah, and your Purkinje fibers are super fast. Parasympathetic system works on the AV node. I'm pretty sure it does, but I'll have to double check that. But yeah, it does change the heart rate. But as we'll talk about in intrinsic firing rates, as long as it's innervating the SA node and if everything else is fine, then that's what's important. So intrinsic firing rate is basically how fast each section of the electrical conduction would depolarize by itself. And so all the SA node and the AV node and the Purkinje fibers have their own pacemaker currents, right? But they go at different rates. So can anyone tell me the SA node's intrinsic rate? Yeah, exactly. 70 to 100, essentially. Then what about the AV node? You guys are smashing this. Okay, 40 to 60, exactly. Good job. What about the Purkinje fibers? Perfect. 15 to 40. And so they could easily ask you a question. They could ask you directly, what's the intrinsic firing rate, or they could say, if the SA and the AV node's communication is off, then what would the intrinsic firing, what would the heart rate be? But now, what determines the heart rate? The actual heart rate that you feel in when you're measuring it, what determines that? Okay, so getting a few mixed responses here. Essentially, what determines your heart rate is the rate that your ventricles contract at, right? Because even if your nodes are firing at a different rate, if that essentially if that depolarization isn't being effectively communicated to the ventricles and they're not contracting on time, then that's what's going to change your heart rate, because your heart rate is how fast the blood's flowing through the body, which is determined by how fast your ventricles contract. Now here we talk about, this is essentially that train analogy. I'm not sure if you guys have heard of this, but essentially, if you have all these different train tracks, train carts, which are going at different speeds, their engines are going at different speeds, they're going to go at, and if they're all connected, they're going to go at the rate of the fastest firing node, which is usually the SA node, right? Because if the SA node is firing at 70 to 100 beats per minute, even if the AV node's going slower, it won't have a chance to depolarize because it's going to be influenced by the SA node before it gets a chance to depolarize at its own rate. And same with the Purkinje fibers. Now, if something was to happen, let's say the SA node's non-functional, right? Then your AV node's going to take over. And so that's what's going to determine the how fast the impulses are going through in the heart. And so then your heart rate would come down to 40 to 60, as long as everything is going through to the ventricles. And then if your AV node is gone, then can anyone tell me a condition where your AV node is gone and then you've got these two different trains going at different times? Exactly. Yep. So your third degree AV block is when you lose your AV node essentially, and your SA node's then firing at 70 to 100, and so your atria are still firing at 70 to 100 beats per minute, but your Purkinje fibers are only firing at 15 to 40. And so at this point in time, your SA nodes might be firing really fast, but your Purkinje fibers are what are determining your heart rate, because they're what's determining your ventricular contraction. And so that's where the difference comes in. So in normal situations, your SA node would be determining your heart rate because it's the fastest. But it's in situations like this where we can make that distinction between the SA node and the ventricular contraction rate. And that's, so an AV block, it's just a mess because nothing's going at the right speed. That's just your autonomics, pretty much what I explained before. Let's move on. And so this is just a diagrammatic representation. So you have your vagus nerves, and so that's your actual innervation. So you lose that completely in a transplant. Whereas your sympathetic, you've got the spinal nerves, but you've also got adrenaline in the bloodstream. Right, cardiomyocytes, I don't like this. This is your depolarization and stuff. So you've got two types of depolarization. One is your cardiomyocytes, it's the actual muscle cells. And the second is your pacemakers, which is itself intrinsic firing rate and how that actually comes to be. Your 4, maybe 5 phases, because there's a 0 phase in there. And you've got your main ions are your sodium, calcium, and your potassium ions. And so luckily they're all positive. So you just need to keep track of what's heading in and what's heading out. If a positive ion's coming into a cell, it's gonna depolarize because it's gonna get more positive. If a positive ion's heading out of the cell, it's gonna repolarize or hyperpolarize because it's gonna become more negative, right? So you don't have to keep track of any negative ions, it's all positive. The sodium and calcium are usually coming in, potassium's heading out. I like to think of this as a banana in an ocean. So inside, there's a lot of potassium, and outside, there's a lot of sodium. Okay, pacemaker action potential, which is your funny current, and that's what's in your SA node and your AV node. That's how you get an intrinsic firing rate where you don't need anything, you don't need any external stimulation. These pacemaker cells will continue firing on their own. So we start with phase 4, because why not, right? Why would you make it easy? There's high sodium ions in the extracellular fluid, so banana in the ocean. There's more salt outside. And they're slowly leaking into the cell through these HCN channels. along with calcium. So there's sodium and there's calcium that's just continuously coming in. And so you start at the lowest is negative 60 millivolts, and it'll just slowly increase, which is called your funding current, until negative 40 millivolts. At negative 40 millivolts, this is when you reach that threshold, this then opens up your L-type calcium channels. Okay, your L-type calcium channels open at negative 40 millivolts, and all this calcium then comes into the cell. You got positive coming into the cell, so you're going to go up you're going to cause a spike, right? Now, I'd say the values for the membrane potentials are important to remember. So there's negative 60 here, negative 40 here. I don't actually remember what the peak is. It's either 0 or positive 10, possibly positive 10. But they can essentially ask you what they've asked in the past, because these can go down to negative 60, your pacemaker action potentials, but your ventricular myocyte potentials can go down to negative 90. And so they have asked a question surrounding that. So then at this peak, your calcium channels close and your potassium channels open, right? And that if there's potassium leaving the cell, then your potential decreases, it hits negative 60, and it repeats again. So pretty straightforward if you just think of the ions movement, right? Sodium and calcium coming in, calcium shoots up because it's coming in, and potassium brings it down. That's your pacemaker potential. So now the potential in the actual ventricular muscle. So this is somewhat more similar to your typical myocyte because it needs an impulse. So if we start at phase 0, okay, when we're starting, okay, we start at phase 4, we have our resting membrane potential, sorry, at negative 90 millivolts, right? So if we start at phase 0, which is your depolarization, you have your sodium channels that open up. These are specifically your fast sodium channels, although there aren't any other sodium channels in the ventricular muscle, so I don't think it's that important. But your fast sodium channels open up, influx of sodium brings it up all the way from negative 90 up to positive 20. Okay, your phase 1 has a slight dip, right? So this is when your sodium channels close, but your calcium channels open. Wait, sorry. Okay, so your calcium channels open and your fast potassium channels close. Calcium channels open. I think this should be open. I'll have a look at this. I'll have a look over this, but essentially there's calcium, from what I remember, is calcium's opened and calcium's coming in and potassium's leaving, which causes that equilibrium, that plateau over here. Okay, I don't know why. I'm a bit confused about this, but I'll come back to this and edit the slide. But essentially what you need to know is at the plateau phase, there's ions leaving and entering that cell. So that's what causes, if there's positive entering and leaving, kind of like your isotonic, there's stuff moving in and out, that's going to cause a plateau in your membrane potential. And then in phase 3, your calcium channels then close. So there's no longer that influx of positive ions, and your slow potassium channels then open, which causes the fast repolarization. So this potassium is then leaving the cell, positive is leaving the cell, and it becomes more negative. And then that just returns it to your negative 90 millivolts. So I'm just a bit confused about the plateau phase, but I'll come back and edit the slide if it is wrong. Okay, cardiomyocytes versus skeletal muscle. How they're different is 2 major things. So one is a longer absolute refractory period. Can anyone tell me why? So refractory period is that time where the myocyte can't depolarize again. Yeah. So essentially a mechanism that just allows your ventricles to completely relax, and you don't get arrhythmias by continuous depolarization of the cell. And so that also that the blood can fill up in the ventricles is another reason. So you don't want it to continuously contract. You don't want that sort of buildup of potentials, action potentials, like you do sometimes want in muscle cells, in skeletal muscle cells. And lastly is this calcium-induced calcium release. And at its very basic level, essentially what it means is that you need external calcium to enter the cell for a cardiomyocyte to contract. And that's the basis for your calcium channel blockers. Essentially targets the importance of calcium in heart cells. And so you have these L-type calcium channels in a cardiomyocyte, and that brings in calcium from the outside. And so in your normal myophysiology, you probably covered the importance of calcium in the whole actin-myosin chain. You also need extra calcium from the extracellular fluid to enter a cardiomyocyte for the contraction to occur. About the longer refractory period, I'll put it in the chat at the end because I'm just a bit short on time, but I'll put a proper explanation, and if it's not in the speaker notes already. Okay, cardiac cycle. This is your Holy diagram. Draw it if you can. I didn't do this last year. I think it's fine, but I'm drawing it out this year for via revision, and it's helping understand it a lot. It essentially gives you your relationships between your pressure and your ECG and your lub-dub sounds, as well as how your pressures overlap, and that causes your valves to open and close. Yeah. Okay, this is your basic summary of your cardiac cycle. So if we start in diastole, which is essentially right after you've ejected, the ventricles have ejected all the blood and your ventricles have relaxed, you've had your lub-dub, so you've had your second heart sound. What happens right after that is now you've got blood coming in to your atria, and they passively enter into the ventricles. So important thing to know is most of the blood that enters your ventricles passively flows from the atria to ventricles, around 80% of the blood, I think. The last 20% that's in the atria then gets pushed into the ventricles via atrial contraction, which is your P wave that you see on your ECG, okay? So now at the end of phase 1A and 1B, you now have all your blood in your ventricles, and you have something called isovolumetric contraction. And so if you imagine the ventricle, when we talk about isovolumetric, that means both the valves have closed, right? Because all the blood is in the ventricles, so there's higher pressure in the ventricles, so your atrioventricular valve closes. And when you isovolumetrically contract the ventricle, it means the volume is the same, but your cardiomyocytes are contracting. And so that causes a sharp increase in pressure, which is your QRS complex that you see. And what happens is that ventricular pressure then increases so rapidly that it then becomes higher than the aortic pressure. So now when you think of what's separating your ventricle and your aorta is your aortic valve. And this can also all be transferred over to the right side of the heart if you just change aorta to pulmonary truncanal. So essentially, with your isovolumetric ventricular contraction, your pressure in the ventricles increases so much that your aortic valve then opens up. And that leads to ejection, which is the T wave that you see on your ECG. As you eject the blood, naturally, there's less blood in the ventricle, so your ventricular pressure decreases. And then you have isovolumetric ventricular relaxation. So when your ventricular pressure decreases, then the aortic valve snaps shut because there's less pressure in the ventricles, there's less pressure behind the valve. And then you have, now again, you have both your valves shut, so there's the same amount of volume, but your ventricles then relax. And that's your second heart sound as well, when the semilunar valves close. And so when your ventricles relax, then your atria are filling up at the same time. And so then there's less pressure in front of the valve, so your AV valve opens up. Does that make sense? It kind of just repeats over and over again. And so anytime a valve closes, that's a heart sound. And so your first heart sound, your lub, is your atrioventricular valve closing when all the pressure increases in the ventricles. And your second heart sound, your dub, is your semilunar valves closing when the ventricles relax. Here's just definitions. End diastolic and systolic volume. So end diastolic volume is the amount of blood left at the end of diastole, which makes sense. And end systolic volume is the amount of blood left in systole. So systole is when you're ejecting all the blood. So after a heart contraction, the amount of blood that's left in the ventricle is end systolic, and end diastolic is the opposite. And so that means that the difference between those two would be the amount of blood that's ejected in a heart contraction. So stroke volume is your end diastolic minus your end systolic. And then ejection fraction, which is just used as a measurement tool, as a standardized measurement tool, is how much of the blood when the ventricles are full. So end diastolic volume is when your ventricles are full. How much of that blood actually got pumped out of the heart is your ejection fraction. Normal, I think, is 60%. And so you can imagine if the heart isn't functioning as well in heart failure or something, this is going to decrease because you're not going to be able to get as much of the blood out. So what's next after a heart comparison? Normal ranges, I guess 60%. Oh, for the milliliters, I don't think that's important at all. I think 60% could be a useful number to know with regards to ejection fraction, but not the volumes. Okay, after the heart, you then have your arteries. Is blood flow through the arteries continuous or is it intermittent? Check it in the chat. Okay. Yeah, so majority are saying continuous, exactly. So the heartbeat is intermittent, but your blood flow is continuous. So how does that work? Is essentially this concept of 2/3 of your blood and 1/3 of the blood. Okay, so I kind of like to think of this as like your savings account and your spending account, right? So in systole, think of that as, in systole, basically 2/3 of your blood volume is kept in the peripheries and 1/3 flow through. So if you think of your spending and your savings, when you get paid, if you spend all your money right away, you're not going to have any money for the rest of the week. And so if all the blood when the heart pumps goes out to the tissues, they'll get blood right away, but then there's no blood until the next systole, right? So all through diastole, which is actually the majority of the time, the tissues wouldn't have any perfusion. And so essentially what we do instead is when we get money, we put ideally most of it in savings, and we just spend what we need, and then we can take out money out of our savings as we need it. And so if we think of the arteries, we have blood that's all come in from the heart. The heart's ejected all this blood in systole. Now we keep 2/3 of it on the sides in our savings. We don't want it. And 1/3 of it flows through. Also, if you use all your blood up right away for diastole, there's nothing keeping your arteries open, so they're going to collapse. So 2/3 of your blood also is required to stay on the sides of the blood vessel wall to keep the blood vessel open, right? And then we go to diastole where the heart's no longer pumping out any blood. And so luckily we have all this blood remaining, and so that remaining 2/3 flows through. So right as soon as the heart pumps, 1/3 of the blood flows through, 1/3 of the blood flows through, and 2/3 flows through in diastole. Does anyone remember where else we've seen 2/3 and 1/3? Yep, exactly. So mean arterial pressure. So this essentially forms the foundation of this formula, which is your mean arterial pressure. They ask about this quite a bit. They'll give you your systolic and your diastolic. So like normal is 120/80. And then you calculate your mean arterial pressure with 1/3 of your systolic. That's how much blood passes through right away. And 2/3 of your diastolic. Another important equation is pulse pressure, which is just the difference between the top and the bottom number, so between systolic and diastolic. With regards to microcirculation, it essentially comes down to your blood pressure regulation and the hyperemias and stuff. So just very quickly, I'll go through all the different components. Meta-arterioles are essentially mini arterioles. They're just the end of the arteriole. So there's no muscles. There's no muscular coat covering everything, but there are some smooth muscle fibers. Your precapillary sphincter, okay? It's essentially, think of it as the bouncer for the capillary. It determines whether or not blood's going to go into the capillary and flow to the tissues or not. Capillary walls they're unicellular endothelium, and they have a very thin basement membrane, but essentially just know that they're porous. So there's a lot of exchange of nutrients and oxygen and stuff going through. And venules are like your veins, weaker muscle, less pressure, pretty much the same relationship as veins versus arteries. This is just a diagram of capillary. So you see your precapillary sphincters here. So you can imagine if they shut close, blood's not going to be able to get through into the capillaries. Now, controlling the blood flow into the tissues. Essentially, there's a bunch of these different theories as to how this works in terms of oxygen availability and how oxygen impacts it. You can read through this if you want, but the two main concepts that you want to know are reactive and active hyperemia. So reactive hyperemia, it's like it describes, it's just a reaction where if your blood supply has been blocked, let's say if you're any situation where your blood supply would get blocked, as soon as it's unblocked, the blood flow to the tissue would increase, which just makes sense. It's just compensating for the loss of blood. Active hyperemia is when the tissue is still getting blood, but it's highly active. So think of all the changes that happen when you're exercising, right? The same things that we talked about in metabolism and stuff. So decrease oxygen, increase carbon dioxide, increase ADP, increase hydrogen ions, right? So when any of these factors happen, the rate of blood flow increases because it causes vasodilation, right? The vessels get bigger, and so there's more blood flow. So reactive and active hyperemia. Now, autoregulation is a similar concept, but it's more to do with arterial pressure. And so when there's a rapid increase in arterial pressure and there's more blood flow, we don't want that to stay consistent. So one of the acute ways of controlling blood flow is this autoregulation, which again, there's two different theories. So the metabolic theory is basically when there's more blood flow, literally just, you know how there's vasodilators on the insides of the vessels, it essentially just washes those away. And when those vasodilators are washed away, the vessel would constrict. The myogenic theory is kind of like the elastic band theory we talked about with the heart. So when there's high pressure, there's more stretch in the vessel. And when the vessel stretches, it then reactively vasoconstricts, and that reduces the blood flow. So two different means to the same action. Yeah, myogenic, just remember that because it's myo, so it's more muscle related stuff because it stretches the muscle and then that causes the muscle to constrict. Here's just a high yield summary table of all your important equations. Yeah, okay. And long-term blood pressure control, I'm not sure how much detail you guys went into the RAS system. Can someone tell me if you guys did this much? You probably did it in antihypertensives, if anything. Yeah. All right, so a little bit in pharm, which makes sense because in pharm you want to control your blood pressure. So this is one of the major mechanisms for long-term blood pressure control. I'll go over it really quickly. You'll go over it a lot more in renal system next year. But essentially, it just involves a bunch of different organs releasing different molecules, and that eventually leads to increasing blood pressure. So we start with the liver. The liver releases angiotensinogen. I know these sound really similar, but just go through it, I guess. It's going to become really important. So your liver releases angiotensinogen, and your kidneys release renin. Renin allows the conversion of angiotensinogen into angiotensin 1. Now, for some reason, your lungs release angiotensin converting enzyme, or ACE. And angiotensin converting enzyme does exactly what you think it would do. It would convert angiotensin from angiotensin 1 to angiotensin 2. Angiotensin 2 is the main acting thing that increases your blood pressure. So what it does is angiotensin 2 then goes to your adrenal glands and causes aldosterone to be released. So your adrenal glands are they just sit on top of your kidneys. They're kind of like little hats on top of the kidneys. And so your angiotensin 2 goes to your adrenals and causes a release of a molecule called aldosterone. And what aldosterone does, it does three things, but by one major mechanism. So what it does is it increases your sodium reabsorption. So if there's more sodium in your blood vessels, by the laws of osmosis and stuff, there's more water that's going to be sucked into your blood vessels because there's more solute. So there's more water that's going to be in your blood vessels, yeah? And if there's more volume of water in your blood vessels, your blood pressure is going to increase. So yeah, this is the system that your farm stuff works on. So your ACE inhibitors target ACE, your ARBs, your angiotensin receptor blockers, they block the angiotensin 2. So essentially you just end up with more angiotensin 1, which is basically useless. But this is your long-term BP control, your autoregulation, and is your short-term, and your baroreceptors as well also do short-term BP control. And I think that's all, yeah, okay. Move on, do we have time for questions, if you're still here?
Yeah, I'm sure we can like go a little bit over time.
Okay. I'll go through a few. So, okay. Yeah, the flow of a vessel is 100 mils a minute. The vessel is 1 centimeter in diameter. If the vessel were to double in diameter, what would happen to the resistance? Yep, exactly. C. So decrease by 16-fold. That's your whole concept of resistance radius to the power of 4, right? So if it's having, or yeah, if the vessel is doubling, that's a factor of 2. So 2, 4, 8, 16. The resistance would decrease by 16-fold. Blood flow in a given vessel is 100 mils a minute. The radius is increased by a factor of 3. If the pressure does not change, what is the new flow? Yep, exactly. A bunch of E's. So E, 8100. So that's just your factor of 3. So 3 to the power of 4, 3, 9, 27, 81. So your new flow would be 81 times the original flow, which is 100. And those are just formulas. Okay, autonomic innervation will only modulate the heart rate since the heart has its own intrinsic rhythm. Parasympathetic innervation involves I'm getting a bunch of A's in the chat. So innervation of only the SA and AV nodes, as opposed to your sympathetic, which also innervates what? Yeah, so your cardiomyocytes. So your sympathetic not only innervate the SA and AV nodes, which can control the heart rate, but it also innervates the cardiomyocytes, which can determine the force that the contraction, that the heart contracts at. And yeah, noradrenaline and adrenaline are just or sympathetic stuff. Someone's running. Because they're running, their heart rate increases. Why does this happen? Yeah, You guys are smashing this. Okay, D. So essentially there is increased sympathetic and decreased parasympathetic, as well as just increasing circulating adrenaline, which is also just increasing sympathetic. It wouldn't be decreased sympathetic and increased parasympathetic because that would decrease their heart rate. Think rest and digest. What's this heart rate roughly? So this is sinus tachycardia. Yeah, exactly. Around 150 beats per minute. So it's just 300 divided by the big squares. So if you look at this, there's two big squares between the peak. So 300 divided by 2 is 150. Nice. So we have a man presents to ED complaining of dizziness and chest pain. An ECG shows an atrial contraction rate of 90 beats per minute, but also shows third-degree atrioventricular block, which is complete blockage of the AV node. What would his peripheral pulse rate be? Yep. So B, essentially your Purkinje fibers are responsible for your ventricles. So your peripheral pulse rate is determined by how fast your ventricles contract, because that's what pushes out the blood. And if you have AV block, your atrium might be contracting at 90 beats per minute, but your ventricles, your Purkinje fibers, their own intrinsic rate is around 15 to 40 beats per minute. So your pulse rate would also be that. And this is just what third-degree AV block looks like on ECG. So you see your P waves, which are atria contracting, and your QRS waves, which are your ventricles contracting. They're just off, right? The atria contracting a lot faster than your ventricles. Shamoli has had a heart transplant. Which of these is true? Yep, nice. C, 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 C. The answer is C. Her resting heart rate would be 100 beats per minute because that's what the sinoatrial node essentially is. The sinoatrial node's intrinsic firing rate is without any parasympathetic innervation. And it can be increased because there's circulating adrenaline in the blood, which would be there regardless of a heart transplant or not. Which of these would decrease cardiac output? Could her heart rate still be decreased with medication? Just with regards to the previous question. Probably, yeah. I think beating at 100 beats per minute continuously could come up with some issues. So I think your calcium channel blockers, beta blockers for sure would block that sympathetic innervation. Potentially, though. Yep, C. So that's decreased venous return. So if you see this and cardiac output, just go with this because that's a pretty simple formula. If we think about the rest, so increase end diastolic volume is the amount of blood that's in your ventricles right before they contract. And so that's your Frank stalling mechanism because it would increase your stroke volume because there's more stretch, and so it would increase cardiac output. Decreasing parasympathetic innervation would increase your heart rate, so it increases cardiac output, and increasing adrenaline would increase your sympathetic nervous system, so increase cardiac output. Okay, systolic pressure is 120, diastolic is 90. What's the mean arterial pressure? Yep. So I'm seeing a bunch of A's in the chat, so that's correct. You take 1/3 of 120, 40, and 2/3 of 90, which is 60. You add them together, and that's 100. I'd hope they would give you guys easy numbers, especially considering we don't have paper in the exam. But I guess you never know. Venous return to the heart of a healthy individual would it be expected to be increased by all of this except Yep. So I'm seeing a few mixed answers in the chat. The answer is B. And this comes back to the formula with venous return equals pressure of the systemic pillars minus pressure of the right atrium over resistance to venous return. And so I talked about how an increase in right atrial pressure would change the pressure difference. And so if the pressure difference is reduced, there's less of a pressure gradient, and so there's less blood coming in. If we look at the other options, so A, increased contractile activity of the skeletal muscle in the legs. That would mean that would cause an increase in pressure. If you think about where the blood is coming in from, towards the inferior vena cava, it's coming from the legs, right? And so if there's more contractile activity in your legs than of contracting your calves, that's going to increase your the pressure, and so that's going to increase the pressure gradient and thus increase venous return. Does the muscular pump also exist in the arms? I don't think so. It's not as direct of a way, like of a path. If you're like subclavian vein coming in, they usually refer to it as the calves being the muscular pump. It's actually kind of interesting because if you feel like you're about to faint, right? If you think of fainting, that's less blood flow to your brain. If you've ever fainted before, or you kind of get that feeling that you're about to faint, and so something they tell people is to contract your calves right before, if you feel like you're going to faint, because what that does is it's essentially your second heart, your calves, and it pushes blood up to your heart, which then, if we think of our concepts, if there's more blood going to the heart, that's increased venous return, which would increase your cardiac output, and that would possibly prevent you from having from passing out, because it'll increase the blood flow through your brain. Just a cool little fact. A patient has the following vitals. What is their cardiac output?
Yeah, just another question about like the sympathetic stimulation to smooth muscle in vein walls. I don't get why it increases sympathetic activity. Could you please explain it again?
Okay, so last question. I'll come back to it after this question, just because everyone's probably doing the maths right now. Yep, so I'm seeing a bunch of B's in the chat. That's correct. It's a bit of a multi-layered question. So if you think cardiac output, that's your heart rate times your stroke volume. So we've got heart rate over here, 60 beats per minute. Then your stroke volume, that's your end diastolic minus your end systolic. So 120 minus 50 is 70, and 70 times 60 would be around 4,200, something like that. So that's around 4 liters a minute. Yep. All right, just going back to this question. Increase in sympathetic stimulation to smooth muscle in your vein walls. This essentially, if you go back to the formula, if you provide sympathetic stimulation to the muscle in the vein walls, that essentially causes your walls to become more stiff. And so it does the opposite of what it would do in arteries. If your walls in your veins are stiffer, that means there's increased pressure in your systemic system of your veins. And that means that when you go back and input it into the formula, it was the pressure in your systemic veins minus your pressure in the right atrium over resistance to venous return. So if you were to increase the pressure in the systemic veins, that would overall increase your venous return.
I get it now. So it's like when you have sympathetic to arteries, it constricts, but in veins, it actually like, if I can say this, makes it like more, patent, if you know what I mean.
So, I mean, it still does make it more stiff, but it increases that pressure gradient going up to the heart. And so that causes it to flow faster.
Okay.
Increase in venous resistance, increase cardiac output, increase in venous pressure. Yep, exactly. So whoever DM'd me regarding the venous resistance and cardiac output, that would be correct. So it's the opposite of arterial. So if there is more resistance in the venous system, that causes a larger pressure gradient. And so there's more blood returning to the heart. The second question is stiffening the vein walls also increase venous resistance, which would in turn reduce venous return. So that's pretty much just what I was saying, where if you were to increase the stiffness of the walls in the veins, that increases the pressure gradient. So with venous return, it's more so about the pressure gradient that you want to consider. Okay, initial depolarization during a cardiac muscle action potential results from Yep. So the answer is D. So it's the fast sodium channels. I'll have to look into why. I think it's because if we go back to the cardiac muscle action potential, just between B and D, I think it's calcium that comes in first. Okay, I'll have to have a look as to the difference between B and D, but I would think that the sodium entering would also cause it. Yep. I guess it's just which one's the better answer because this is more specific towards the fast sodium channels. But I'll have a look. And okay, I'm way over time. Oh, that's the end. Okay, cool. That's all the questions I have. What I have a few more. Yeah. Yep. Move on.
Thanks, Ajat. Always great. So I think next up, final provisional lecture of the year for you guys. We'll have farm. So I'll hand it over to our farm lecturers.
Yep, so I'm just going to start by sharing screen. Yep, so I know you've been through quite a bit already, so I'm just trying to keep this as short as possible. Yeah, so if you have any questions, just type in the chat. I'll probably answer it at the end of the lecture. Yeah, if not, then just start. Some acknowledgements. Just a quick thanks to faculty lectures and other learning materials, e-pharmacology, which is quite important. Stella Le's revision lecture last year, which I used a little bit of resources from, and other online resources. So some things that I want you to take note for pharmacology. I think for pharmacology, a lot of it is memorizing, but what you want to really grasp is what the medicine is used for. So it's a balance between summary and details. You don't want to overload yourself with too much details about side effects and the nitty-gritties, but you want to try to understand broadly what it's about. Yeah, as I said, questions asked in the chat. If not, you can follow up using my email. Yeah, so just a rough prediction. This is last year's Sem 2 kind of exam. We had 12 questions of pharmacology out of 97, so that's a lot about 12%. Yeah, so this is just a brief overview. I'll be probably covering these 5 topics today. So pharmacokinetics, your ANS drugs, your pain medicine, your DMARDs, as well as your cardiopharmacology. Yeah, so first for pharmacokinetics, it's basically how the body uses drugs. This is a really good diagram. If you understand the whole of this diagram, you're pretty much set for pharmacokinetics, and it's pretty self-explanatory as well. There are some big banners that you need to know. First is absorption. So, you know, if you administer a drug, you have different modes of administration. You have IV, subcutaneous, as well as oral. The next thing that you want to know about is bioavailability. So it's defined as the percentage of drug that reaches your systemic circulation, basically entering into your blood to go around. Yeah, so obviously if you inject directly into your veins, you have a higher bioavailability. But if it goes through the oral route where you have to absorb it through your GIT, then you might not get as high a bioavailability. Next thing is therapeutic index. It's basically the median lethal dose over the median effective dose. So I've put it in brackets that higher is safer, because if you have a higher lethal dose, I think that's better, because the tendency to take on a lethal dose is lower. Whereas if you have a smaller effective dose, that's also better. Then you don't have to take so much medication. Next is the aspect of attribution. So the volume of distribution is just there, total amount of drug in the body over the drug blood plasma concentration that has the drug. And factors affecting distribution is size. So if it's bigger, then it's confined to circulation, right? It cannot pass through the cell barriers. Lipophilicity means that it likes lipids, it likes fats, so it gets trapped in fat and maybe not going to the places that you want it to go. Ionization could mean that it gets excluded by cell membranes, because the cell membranes are somewhat polar, as well as the plasma protein binding. So if it binds to the proteins within your plasma, it doesn't get distributed evenly. So the mnemonic that I use is slip. So it's like slipping something under the table to distribute something. Yeah. Next is metabolism. So there's metabolism that usually takes place within your liver. Broadly, there's 2 phases. Phase 1 is more catabolic. So you're trying to break it down. You're trying to functionalize it, so that it can be used by the body. You increase its polarity so that it's more water soluble, as well as it's potentially toxic, because now you've activated the drug to be used. Phase 2 is kind of the opposite, preparing the drug for excretion. So it's anabolic, involves conjugation, so it adds on elements and most likely results in inactive products. Last thing for pharmacokinetics is the elimination. So there's just 2 orders that you need to know. 0 order, which means that it's the same amount of drug eliminated per unit of time. That's why the graph is straight. For example, it's like 2 milligrams eliminated per minute. So it's very constant. And the other one that probably is a little bit more important is first order elimination, where the proportion of the drug is eliminated per unit of time. So it's about 2% of the available drug that's eliminated per minute, right? So you can see at the start of time, where the drug concentration is really high in the body, it drops a little bit more steeply. Whereas when you're coming towards the end, where the drug or the plasma concentration of the drug is lower, the excretion rate is slightly lower. Okay, so this depends on volume of distribution, right? So if you distribute it more, it could either be eliminated faster or slower, as well as your clearance, which is your plasma volume cleared divided by time. How it affects the body. It affects the drug's duration of action. So if it gets eliminated too quickly, then the drug doesn't stay in the body for that long, and then you have less effects. You also have to understand the time to reach steady state. So it's where the absorption equals the excretion, and that's when you know that a drug is at steady state, as well as affects the elimination time of the drug. All right, so that's mainly it for pharmacokinetics. Next, we're going to go into autonomic nervous system drugs. So the 2 main things that I want you to understand is parasympathetics, just think about it as rest and digest. And how I remember this is like para, so it's like paralyzed. So you're just like lying in a bed, resting and digesting your food. As well as sympathetics, where you have a fight or flight kind of idea. All right, so first is your anticholinergic drugs, which I bracketed as your parasympathetic nervous system. Why I do this is because this involves two main pathways. First, your nicotinic receptors, which are your ganglionic transmission, and these are not too important. The other one is your muscarinic pathways, or your muscarinic receptors, which affects directly on the target organ within your parasympathetic system. Okay, so when you think about agonist, right, you would think about allowing parasympathetic nervous system activity. So you have pupil constriction, right? You have your digestion as well as GIT motility, as well as decreased heart rate, right? So this is rest and digest. Whereas on the other hand, if you have an antagonist, right, it inhibits parasympathetic activity. So you have sympathetic activity, which is fight or flight. You have your pupil dilation. You have stoppage of your GIT motility, which causes you constipation. Your heart rate increases, causing tachycardia, and your airway gets dilated because you need more air. Okay. Yeah. Next is your adrenergic drugs, which is mainly your sympathetic nervous system, as you can see in the diagram right below it. So same thing for agonists, you want to remember that it allows sympathetic nervous system activity, and for antagonists, it inhibits sympathetic activity. Pardon me for the mistake there. Inhibits sympathetic activity, so it allows for parasympathetic activity. The main 5 types that you need to know about adrenergic drugs is A1, which is close to your nerve ending, so it's surrounding your vessels. You have A2, which is your presynaptic nerve terminals, and this is honestly not too important, but it involves your transmitter release. B1, B2, B3 is just found in different places of your body. So it's found in your heart, lungs, as well as GIT. So this will be important when we talk about drugs and we talk about what they do. All right, so this is just a really quick overview of parasympathetic drugs as well as sympathetic drugs. It's good because if you have a sheet like this, you can just read it before you go into the exam, and then you can remember everything. Okay, so if I can just go through one by one quickly. Atropine is a muscarinic antagonist, right? So remember, antagonist means that it encourages sympathetic activity, right? So it's for severe bradycardia, it's for AV blocks, and what it does is increases your heart rate and improves your AV conduction. Okay, next is hyoscine, same thing, antagonist means that it encourages sympathetic properties. So it's for motion sickness, somehow it relaxes your muscles. Okay, I'm gonna have to check back on this again. But moving on, ipratropium, which is an antagonist, right? So it encourages sympathetic activity, so it causes bronchodilation. Pyridostigmine, which is your acetylcholine enzyme inhibitor. So the enzyme basically helps to break down your acetylcholine, right? Which means that it reduces your parasympathetic activity. So if this is inhibited, right, your acetylcholine is not broken down, right, and you have increased acetylcholine within the synapse, which means that it encourages parasympathetic activity. Okay, your botulinum toxin, which is Botox, it's your acetylcholine release inhibitor. So if you inhibit the release, it means that you have less of acetylcholine, which means that you have decreased parasympathetic activity, which means that maybe your muscles tighten, right? Which is why people inject Botox into their face so that it looks more turgid. Next is your sympathetic drugs. You have dobutamine, which is your B1 agonist. You know that B1 is for your heart, right? So agonist means that it encourages sympathetic action, increases cardiac output by increasing heart rate. Next is atenolol. So it's your B1 antagonist or B1 blocker. So it's also for your heart, but it encourages parasympathetic action. So this is mainly for heart failure, where it reduces your heart rate. Next is salbutamol. This is your B2 agonist. So B2, you remember, it's for your lungs. agonist means that it encourages sympathetic action, and this causes bronchodilation. And those that I highlight in orange is pretty high yield, so it's probably going to come out in your exams. So just remember or pay special attention to it. Next is cocaine, is your noradrenaline uptake inhibitor. So if it prevents noradrenaline uptake, it increases noradrenaline within the synapse, which means that it increases your synapse, your sympathetic activity. Chlorgeline, which is your NA enzyme inhibitor. So we know that enzyme breaks NA down, and this inhibitor prevents NA degradation, which means that more noradrenaline is reduced, so sympathetic activity increases as well. Lastly, carbidopa, which is dopa decarboxylase inhibitor. I think this is something that comes up more during year 2, but for now, just you can just memorize it. It inhibits noradrenaline production pathway. So in the end, you decrease noradrenaline and you inhibit sympathetic activity. Okay, so I know there's a lot of names. Like I said, just remember what they do. Remember the classes that they fall under, and then it's a lot easier to go from there. All right, so that's for your ANS. Next, we're gonna go into pain medicine. Today, I'm just gonna cover NSAIDs as well as SIDS. I heard that William covered anesthetics and opioids yesterday in his lecture, so I'm not gonna redo that. All right, so NSAIDs are non-steroidal anti-inflammatory drugs. So there's 2 COX that you need to remember. COX-1 is the good COX, right? Because this basically produces prostaglandins for platelet aggregation, thromboxane. It encourages blood flow in the kidneys. It encourages GIT mucosal protection, as well as prevents bronchoconstriction. So you see all these things are pretty good things that help your body. COX-2 is labeled bad because it encourages inflammation, as well as encourages vasodilation. Okay, so in terms of drugs, there are 2 main classes. The old drugs, right, are non-specific. So they have both COX-1 and COX-2 blocking properties, right? So it prevents inflammation, prevents vasodilation, as well as prevents all the good stuff, right? And if you see at the bottom, the non-specific ones are good for the heart, bad for the GIT, right? Because you lose your GIT mucosal protection. And overall, NSAIDs are just bad for your kidneys. So that's just something to remember. The newer drugs that we have now are COX-2 specific. However, they're bad for the heart, good for the GIT, and bad for the kidneys. They're bad for the heart because now you have platelet aggregation, right? Increase of platelet aggregation without vasodilation, right? So you can imagine that your vessels are being constricted, but at the same time, you're getting more blood clots, right? So in the end, you're going to end up with a heart attack or something even worse. Okay, so that's why it's bad for the heart, good for the GIT, but bad for the kidneys. Next is steroidal anti-inflammatory drugs, and the main type is glucocorticoids. It has anti-inflammatory properties, and it acts on phospholipase A2. So that's the diagram at the bottom. This is pretty key, so just remember phospholipase A2 for SIDS. Yeah, it also helps by giving immunosuppressive properties. The side effect that you really want to take note of is Cushing syndrome, because glucocorticoids contain an excess amount of cortisol, right, which is your stress hormone. And when your body's put under stress, it wants to increase its blood sugar, right, to be able to maintain that fight or flight response, as well as to increase heart rate, as well as to, do many things, right? So if this sugar builds up, you get things like your buffalo hump, you get obesity, you endanger the heart, right, for cardiac hypertrophy. Yeah, so these are just some things that you can think about and memorize. All right, so again, the cheat sheet of NSAIDs and SIDS. NSAIDs, you have non-selective, remember, bad for the heart, bad for the GIT, good for the heart, and bad for the kidneys. First, you have aspirin. So it's a simple analgesic, right? It's anti-thrombotic, right? And just remember that salicylism increases aspirin elimination. So if you have aspirin overdose, which is quite common because it's such a attainable drug, you can use salicylism to treat it. Next is ibuprofen. same thing, is a simple analgesic metabolized by the kidney, and diclofenac, which is used more for rheumatoid arthritis or chronic pain. We'll probably touch on that a little bit later. Next is COX-2 selective. Same thing, bad for the heart, good for the GIT, and bad for the kidney. Okay, so meloxicam and celecoxib, just remember these things. You don't really have to dive into the side effects as much. Next for SIDS, you have 3. So you have prednisolone, dexamethasone, as well as fluticasone. Okay, the main one that you want to remember is fluticasone because it's inhaled, right? And what this does is because there's so much of this drug within your throat area, it causes sore throat dysphonia, as well as oral infections. And this is a preventer in asthma, which you'll probably cover next year. So the last drug that I want to raise is paracetamol. So it's neither an NSAID nor a SID, right? But how it is useful is it's a simple analgesic, right? So if somebody presents with pain, right, and you don't want to give them such harmful drugs, what you can do is you can just give them paracetamol, which is what you get over the counter anyways. So you get less side effects, but obviously if you overdose, it gets metabolized by the liver, and that's when you get some issues there. Okay, so just remember these 2. All right, so that's 2 out of 5 done. We're just going to move on to DMARDs, and the main 2 things that we're going to cover is drugs for rheumatoid arthritis as well as drugs for gout. All right, so for arthritis, you basically have a chronic autoimmune inflammation, which means that you have a lot of white blood cells at the joints of bones for no reason, or rather for autoimmune reasons. Okay, so these are just the drugs that you need to remember. Most of them, right, are inhibiting the synthesis of DNA in T cells. So if you inhibit the synthesis of DNA, you reduce the amount of T cells, right, which is the white blood cells that are causing this kind of inflammation, right? So methotrexate, leflunomide, azathioprine, and mycophenolate. Okay, so all these inhibit DNA synthesis, which reduce T cells. You have cyclosporin, which inhibit the cytokines production, and hence the T cells don't get activated. So this is somewhat slightly different. And you get, and the last drug you have to know is hydroxychloroquine, right, which is an immunosuppressant, but the mode of action is quite unclear. For gout, you basically have uric acid, which crystallizes in the joints, which again causes inflammation by white blood cells. So for this, you can actually target the uric acid site. So there's allopurinol, which is pretty important. Basically decreases uric acid production. Yeah. So if you decrease that, then you won't have as much crystals in your joints. Next is probenecid. It blocks the reabsorption of uric acid in the kidney, which means that you pass out more uric acid, which is also good for you. And last is colchicine, right, which inhibits leukocyte migration into joints. So if you stop that, then the leukocytes can't go into the joints to cause inflammation. Okay, but the main thing that you want to know is allopurinol. Okay. All right, so we're going to go into cardio. I think cardio was quite recently addressed by Jack. So just going to go through the pharmacology here. So we're going to start with antiarrhythmetics, right? So this can concern 2 scenarios. So it's either too fast or too slow, right? So if it's fast, you want to slow it down. And it's what I put here as slow is smooth, and smooth is good, right? So you want to slow everything down so that the heart starts beating properly and slowly. Okay, so first you have an Na plus blocker. So if you remember the banana inside the salt water, right? So you reduce ion conduction by blocking Na channels, right? So the Na doesn't go into the banana as fast, right? Which means that the conduction is slowed down, which means that the heart beats slow. So that's class 1. Class 2, you have beta blockers. Remember, beta is for your heart and beta is sympathetic, right? So if you block it, you have parasympathetic activity coming, right? So you reduce your heart rate by slowing your SA node or your AV node, right? So everything slows down like what I said, right? But obviously all these have the side effects of bradycardia, right? Because you are slowing down the heart. Next is your K blocker, right? So you need potassium to come out of the banana, right, to repolarize, right? So if you block it, you have prolonged repolarization, and hence you slow down the entire part, because if you can't repolarize fast, you can't get polarized again, right? Amiodarone contains iodine, so you just need to take note that there's side effects of thyroid toxicity as well as hepatotoxicity. Yeah, so because of the high levels of iodine. Class 4 is your calcium channel blockers. So you know that calcium is needed to contract your muscles, right? And these are mainly for the heart, or heart specific calcium channel blockers. And we'll see a different type in antihypertensives. But these basically reduce your heart rate by preventing calcium influx into your cells. So if you don't have enough calcium, you can't beat as hard or as fast as you would like to. Okay? And obviously this causes slowing down of your heart rate and all that. Okay, so this is for if your heart is beating too fast. Yeah, this is others. So digoxin, which is used for if your heart is beating too slow. Sorry about that. These are also for if your heart is beating too fast, right? It reduces your heart rate by blocking AV conduction. And adenosine, which is used for VTAC, reduces your heart rate by blocking AV conduction. You just want to take note a little bit more for adenosine because it presents with the least side effects. So you want to use it as a drug of choice. Okay, so that's for antiarrhythmetics. So depending on whether it's going too fast, going too slow, just take note what drugs you can use and what drugs you shouldn't use. Next for antihypertensives, some terms to recognize. Inotropic, which is regarding the contraction or the strength or how hard your heart pumps, whereas chronotropic refers to the time or rate. So it's how fast your heart pumps. Okay, so the way I think about heart failure, right, is if you fail at something, you can either work harder, right, so to overcome the obstacle, or you can reduce the resistance, so you can lower down the obstacles so that it's easier to get over it. So it's the same thing for heart failure. Sorry, before we go into the next slide, just want to show you the therapeutic progression, right? So if you're younger and less than 55 years and a non-Black person, you want to use either A or B, and I'll go through what A or B are. And if you're older than 55 years or you're Black, you want to use C or D. And again, I'll go through what C or D are. If that doesn't help on your first line of treatment, your second line of treatment would be to add one of each group, right? And if that still doesn't work, third step would be to add either A or B, including C and D, right? And obviously for then you probably need to use something that is much stronger. Okay, so at the bottom there's the legend, right? The A, B, C, and D. But how it affects the patient, I'll go through in the next slide. Okay, so your ACE inhibitors, right? So I think just now you went through the RAS system, right? Where you have angiotensin 1, angiotensin 2, and then after that it leads to a bunch of different effects on the body, right? So your ACE1, ACE inhibitors, sorry, you have anything that ends with pril, right? So captopril, perindopril, enalapril, and you have a side effect of hyperkalemia. Okay, so this basically increases bradykinin because it doesn't break it down and causes dry cough. So dry cough is just something that you have to remember for ACE inhibitors. Yeah, so once you see dry cough in a patient with hypertension, just think of ACE inhibitors. Okay, so what this does is it inhibits angiotensin converting enzyme. So ACE with the X up on top, right? So by blocking this, you don't get angiotensin 2 and you don't get any of the effects. So you don't get vasoconstriction, you don't get sodium water retention, which means that you lose more water, right? Which means that you reduce blood volume, you reduce the amount of blood the heart needs to pump, and then you reduce the amount of resistance. Okay, so if ACE inhibitors don't work, the other alternative that you can do is ARBS, right? Which is basically angiotensin receptor something. Sorry, I forgot. Okay, but basically these end with sartans. Okay, so anytime you see sartans, just think of ARBs. Side effect, same as ACE inhibitors, is hyperkalemia. The other way that you can lose water is by peeing it out. Okay, so you use diuretics. You have your loop, your thiazide, as well as your K potassium sparing diuretics. So why it's named this way is because your loop is within your loop of Henle, your thiazide is in your distal convoluted tubule, and your K sparing is just K sparing. Okay, so it encourages the excretion by preventing iron reabsorption, which means that if there's more iron within your pee, then more water flows out as well via osmosis. Okay, next. Yeah, so next we're going to talk about other kinds of antihypertensive. So just now we went through A and E, right? A, we had ACE inhibitors, ARBs, and D, we had diuretics, right? And now we're going through B and C plus others. Okay, so B is a beta blocker, right? So it reduces your heart rate by slowing your SA or AV node activity. So remember we went through this, beta meaning affects your heart, as well as blocker means that it encourages parasympathetic activity. So it reduces your heart rate by slowing SA or AV node activity. Next you have your calcium channel blockers, right? And these are peripheral linked, right? So remember when we talked about arrhythmia, those are heart-related channel blockers, right? Now we're talking about peripheral calcium channel blockers, right? Which means that these affect more of your blood vessels rather than your heart itself. So what it does is it causes vasodilation, right? Because your smooth muscles don't contract as much, which reduces afterload because now you have a lowered BP and you have a lowered resistance against the heart pumping.